The session will also be live on social media and YouTube and can be accessed anytime. So IHC's is the initiative on hemophilia care. It's a sensitization program, not just for patients, but definitely for healthcare experts and for the bureaucrats, because this is all about making policy changes. This is about discussions, understanding the challenges, innovations, and experience shared by medical experts and patients. We have been having this for many years. Only during the COVID time there was a break. Last time also we had a grand IHC at Delhi. Before we begin, I'd like to acknowledge the tireless efforts of the Hemophilia Federation India and National Health Mission for their dedication to help in hemophilia care as well as in IHC. It is due to the support of National Health Mission that we have been able to make the participation of NHM doctors and officials from throughout the country every time. So I'll just share the same in Hindi as well. आज हम आए हैं IHC 8 इनिशिएटिव ऑन हीमोफीलिया केयर 8 जो हम करते आ रहे हैं नेशनल हेल्थ मिशन के कोलैबोरेशन के साथ। इतने सालों में IHC हमारे हीमोफीलिया कम्युनिटी का एक लैंडमार्क इवेंट है और इस जर्नी हम कंटिन्यू कर रहे हैं अवेयरनेस बढ़ाते हुए और हीमोफिलिक्स को एक इंक्लूसिव केयर पूरे देश में प्रमोट करते हुए। आज हमारे साथ है एक्सपर्ट्स, हेल्थ केयर प्रोफेशनल्स, पेशेंट्स, केयर गिवर्स जो अपना नॉलेज, एक्सपीरियंसेस और बेस्ट प्रैक्टिसेस शेयर करेंगे। हमारा प्रोग्राम इंसाइटफुल सेशंस से भरे हैं, पैनल डिस्कशंस भी है और पर्सनल स्टोरीज भी है पेशेंट्स के एज वेल एज हेल्थ केयर प्रोफेशनल से। सो ये हो रहा है 8वीं बार ओनली बिकॉज हीमोफीलिया फेडरेशन इंडिया, नेशनल हेल्थ मिशन और हमारे सारे हेल्थ केयर एक्सपर्ट्स इसके लिए बहुत सपोर्टिव है। ये प्रोग्राम लाइव भी जा रहा है यूट्यूब में और सोशल मीडिया में, तो आप ये बाद में भी देख सकते हो। हमारा प्रोग्राम जल्दी ही स्टार्ट होंगे। हम वेट कर रहे हैं हमारे चीफ गेस्ट के जो अभी ऑन द वे है। ये सेशन सिर्फ लर्निंग का नहीं है, IHC सिर्फ लर्निंग का नहीं है, ये नेटवर्किंग और कनेक्शन बढ़ाने का भी एक जगह है। तो हमारी रिक्वेस्ट ये है कि आप ये मौका ज़रूर यूज़ कीजिए नेटवर्किंग और कनेक्शंस के लिए, क्योंकि ऑल दीज ईयर्स हमारे पूरे देश में केयर इम्प्रूव हुआ है इस तरह का शेयरिंग ऑफ एक्सपीरियंसेस बिटवीन एक्सपर्ट्स, वो हेमाटोलॉजिस्ट हो या फिजिशियंस हो या पीडियाट्रिशियंस हो या जनरल प्रैक्टिशनर्स हो, केयर गिवर्स हो या पेशेंट कम्युनिटी हो। ये नेटवर्किंग और कनेक्शन से ही हम एक दूसरे से एक्सचेंज कर पाते हैं। तो प्लीज़ कंटिन्यू टू डू दैट। वी विल बी स्टार्टिंग द प्रोग्राम in some time as soon as our chief guest arrives here. Also, we request to whoever is present in the lobby to please enter the hall and be seated please. जो भी वेदी के बाहर है प्लीज़ हॉल में आके बैठ दीजिए। Hello all, please come into the room because we'll start with the scientific sessions first and we'll break for the inaugural ceremony. So please, I request all of you to please come into the hall and please be seated. We'll be starting with our first speaker today. I request you all to please enter the auditorium and be seated in 5 minutes so that we can start the IHC 8 with the scientific session. Good evening, everyone. Namaste. Please have a big round of applause for our chief guest today. I would like to extend a warm welcome to our chief guest, Dr. Harsh Mangla, Director, National Health Mission. We'll start this program with the inaugural ceremony. Thank you, sir, for graciously agreeing to join us today. We'll start this program with the invoking of the lamp. I request the dignitaries to please move forward for the inaugural ceremony. So I would like to extend a warm welcome to our chief guest, Dr. Harsh Mangla, sir, who have graciously agreed to join us today in invoking the lamp and inaugurate IHC 8. I request our President, Premru Palwa, VPM Cecil Ross, VPF Jagdish Sharma, VPD Ramu Gadkar to please join our chief guest.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव।
As the lamp is lit, let it remind us of the light of hope and inspiration that guides us forward. Thank you to our esteemed guests for that beautiful ceremony. I request the guests to please come into the dais. So we'll start the first day of IHC with the national anthem. May I request everyone to please stand for the national anthem and join me in honoring our nation.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता। पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा। विंध्य हिमाचल यमुना गंगा उच्चल जलधितरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you. Please be seated. I request our President, Shri Premru Palwa, to please welcome our chief guest with a bouquet of flowers, a token of our love. Thank you, sir. Now I will call upon to the podium our Vice President Development, Mr. Ramu H. Gatkar, for the welcome address.
Yes, thank you, Dr. Anu. नमस्कार, मैं रामू गडकर हीमोफीलिया फेडरेशन ऑफ इंडिया की ओर से सभी सम्मानित अतिथिगण और सभी समर्थकों का और मेरे साथी सदस्य जो संपूर्ण भारत से आए हुए हैं, मैं बहुत खुशी और गहरी कृतज्ञता के साथ हीमोफीलिया केयर 8 के पहल में आप सभी का तहे दिल से स्वागत करता हूं। आप सभी ने जो हमारे प्रति अटूट समर्थन और प्रतिबद्धता दिखाई है, उससे मैं कृतज्ञ हूं। हमारे इस मिशन में आपका जुनून और विश्वास हमारी सफलता के लिए आप सबकी हमेशा प्रेरणादायी रहेगी। आप और हम साथ मिलकर अनगिनत हीमोफीलिया के जिंदगियों को छुआ है और उन सबको सशक्त आप सब ने बनाया है। एक देश एक उपचार के लिए आपका सहयोग की हम सराहना करते हैं। मुझे विश्वास है कि हम अपनी प्रतिबद्धता पर दृढ़ रहकर हमारी मंजिल पाकर ही रहेंगे। आज हम सब इस सभा को नवीकृत प्रेरणा और दृढ़ संकल्प के उपरोक्त उत्प्रेरक के रूप में उपयोग करके और हमारे मिशन को प्रति आपके प्रतिबद्धता को पुष्टि करते हुए और हमारे सभी हीमोफीलिया के बेहतर भविष्य की तलाश में आपके प्रयासों को दोगुना करने का संकल्प करते हैं। मैं यहाँ पे एक देश एक उपचार के लिए मैं एक कोट भी कहना चाहूँगा। सपने वो नहीं होते जो नींद आने नहीं देते, सपने वो होते जो सोने नहीं देते। तो आइए हम सब मिलके हमारे सपनों को साकार करते हैं। एक देश एक उपचार का जो हमारा संकल्प है वो हम पूरा करते हैं। जय हिंद, नमस्कार, थैंक यू।
Thank you, Shri Ramu Gadkar ji. Now I request our President, Mr. Premru Palwa, to speak about HFI and a community request.
Good evening all. Hearty welcome to you, sir. Thank you. I would like to start my talk by thanking Sri Harsmangala sir personally and on behalf of the entire hemophilia community, many of the program officers here and doctors present in this room. It's only because of him that our product has been included in the EDL, and thank you so much for you and the entire government, sir, and NHM for including it. It was a big, when certain things were not happening, we were really worried, and you took it upon yourself and made sure that this happens. Thank you so much, sir. Now, going forward in my presentation, I would like to talk a little bit about Hemophilia Federation India. So, who are we? We were started and founded by late Ashok Bahadur Verma in 83. Verma ji, Ashok ji, that in the 80s there was hardly anybody knew anything about hemophilia, no treatment. He had an incident where he lost one of his leg because of a bleed. We had to amputate his leg. In spite of that, he went to across the nation building chapters. So our current status is we are an NGO with 100 chapters and over 350 HTCs across India. Our vision is one country, one treatment, hemophilia without disability and children free of pain. Our mission is to locate undiagnosed PWH, educate them, give them the right facilities, and then to advocate more about hemophilia. So we have 100 chapters in 350 centers. Like I mentioned, this is the geographical spread. We are present in 90% of the states, and except for very small few UTs, we are present across India. We have divided India into 4 regions, and it's color-coded. So what does HFI do? We basically connect people. Okay, connect people and their families, because there was a sense of loneliness and we were the only people suffering. We were thinking that way. We have connected people, created a platform for them to voice their concerns, voice their difficulties. This being a genetic disorder, it not only affects the person suffering, but also affects the parents and the entire family. Neighbors are taking people to the hospital, so there's a whole ecosystem which gets involved with the person who is affected. So, for which, okay, now we have connected the PWH, we have to, create awareness, both within our community and outside our community. We provide a lot of psychosocial support for mental well-being, because for a genetic disorder where you are born with and take it till the last, there's a lot of mental trauma which the person gets into, the family gets into. We support them in that way. We also have projects where we economically rehabilitate them, provide them better education, support them in improving their quality of life. We have a fantastic data management system. Once a person is identified, he's put into the data system where we know exactly in which PIN code, which village, how many PWH are there. So the burden of hemophilia in India, when you look at, okay, the highest number of hemophilia patients diagnosed is in India, hemophilia A. So hemophilia is, as you know, it's in A and B. And in hemophilia B, we are the second largest. We come behind the United States. So if you look at, one more thing which I want to tell you, sir, is our identification is close to 20%. We have identified only 29,000 PWH across. Every year it's increasing, but ideally there should be 160,000 PWH. So when you consider that, okay, when you're talking about it, every PHU should have approximately around 6, and we are looking at around 90 PWH in a district level and close to 250 PWH per Medical College of India. So what is the need? Okay, our need is basically factor. Okay, then the sky, it's a deficiency, it's not a disease. So when it is provided, then the sky is the limit. So what we call 3 pillars of effective hemophilia care management is, we want to identify people early, provide them proper management with accurate treatment, okay, which involves multidisciplinary cares, physiotherapy, dental, etc. care, and there should be an option of prevention. Ideal case would be that you have every state has a cognitional lab, then adequate treatment, which means factor 8, factor 9, Von Willebrand factors, non-factor therapy, and inhibitor medication, which is factor 7 and APCC as of now, as the treatment have advanced. We want to have, it's not only about procuring these factors, it's about a proper system of mechanism of procurement and also distribution based on a data or some kind of a science, for which we need a a national or a state level registries to be maintained. And ideally, hemophilia is a very funny disorder. The quicker you give treatment, the lesser the suffering. So the access for treatment should be in every district. And obviously, when there is complications, we need to have a comprehensive system. Where we partner a lot with the government and several state governments is in education and training of personnel. An option of prenatal diagnosis is something which is needed, and easy access to disability certificate, employment and rehabilitation support, and finally insurance cover. We thank you from the bottom of our hearts for supporting the community. This is for one and all that we support you. I mean, we really appreciate the support which we have received in this room, which is the reason many of us are standing here, and we are very happy and we are very thankful towards you. So we have a request. Our final request is that there are issues in several states. Some states are doing fabulously well. Some states can do better, but we thank every state for supporting us. Every state is supporting us, and primarily because of Government of India and because of you. And what is needed is a national guidelines or treatment which makes the entire system, the entire ecosystem much more better and more smoother. Thank you so much, sir.
Thank you, President, for such a concise and effective communication of the request of our very large community of India, the bleeding disorder community of India. Now, I request our Vice President Medical, Dr. Cecil Ross, to please come to the podium. The topic, sir, is going to share here is defining what a person with hemophilia needs, the medical perspective. Welcome to the podium, sir.
Well, thank you, Prem, for giving a perspective on what the patient needs. And I will speak from the perspective of a doctor, what we want to deliver to the patient with hemophilia. Because most of the time, you find that if proper treatment is not given, they become crippled by age 18, 20, and then we do knee replacements by about age 20, 25, which normally in the general population happens at age 60, 65. So what is the disease of hemophilia? The product selection, how do we select products, and what guidelines we need to follow. So if you look at what a patient needs, he needs regular medical care. He needs that prevention of inhibitors should be there, because once the patient develops an inhibitor, the cost will go from 3 lakh to treat a bleed to about 60 lakh per bleed. Then we need to see what emotional support patients can get, because a lot of patients are distraught, they become crippled, they can't give exams, school absenteeism and children, job opportunities lost, and so on. And therefore, there's a need for education and advocacy, because this is important to be able to integrate all these people into society. So normally, if you looked at patients who bleed spontaneously, they bleed at home, they're watching TV or something like that, and they bleed suddenly into the knee joints or elbow joints or something. So what we do, we give rest, we give ice, we give comprehension, we ask them to elevate. I mean, this is at home, what we do. And normally, what we suggest is we give them factor 8 or factor 9, as the case may be, and that is available at home therapy. But majority of the people are not able to afford home therapy, because if you do a prophylaxis, then you have to actually give them the treatment much more often. Like, for example, if you take a short-acting factor, you have to give them much more frequently. But if you take a long-acting factor, it's a little lesser. But now there are newer treatments on the horizon, which are non-factor concentrates, where you can maintain a factor level of about 30%, so a person is basically normal. So he can do about normal work and is given once a month subcute. Then there is, of course, gene therapy, which can actually cure, which is on the anvil, and which will probably be starting the clinical trials in about 8 to 10 months. I said about inhibitors because the moment you develop inhibitor, about 15 to 30% develop inhibitors in our country, and with the availability of factor at the government level and at the private level, the chances of you getting inhibitors are much more higher. And therefore, once the person develops inhibitor, the cost treatment goes up to about 60-70 lakhs, 60-70,000 per bleed. So that is the problem. So once you develop an inhibitor, it is difficult to control bleed, it's 70% higher mortality rate, it's twice the hospitalization that's necessary for a person normal with hemophilic as it is, the chap keeps getting admitted to the hospital before, and the annual cost goes 3 times. So how do we select products in order to avoid all these inhibitors? You have the product purity, you have viral safety, then you have to have viral inactivation procedures, and you have to have viral removal procedures. And if you then look at purity and viral safety, there are a host of procedures that have to be done, and if these are not done in a proper way, then the chance of you developing inhibitors are higher. Similarly, if you look at viral safety, the viral removal procedures, there are certain procedures which are recommended, and these are gold standard. So if you actually look at filtration, it's better to do a filtration process by 15 to 20 nm so that you can remove all the viruses. But if you look at 35 mm filtration, then the chances of you getting a viral infection is a little higher, even if it is a product that is there in the thing. So before, what used to happen when Prem was saying that, in the 1980s and 90s and even early 2000s, then what we used to do, we used to give treatment episodic, that when a person bleeds, we give them. So when you had this episodic treatment, the fellow would have a destroyed joint by age 18-20. Now what we are doing, we give them prophylaxis so that there is a continuous level of factor VIII that is there, so the person can become normal and he has normal development of joints. So you have to give prophylaxis. So prophylaxis can be either by standard half-life or extended half-life or newer therapy options. So the idea of giving a prophylaxis is that if you start prophylaxis at any age, the bleeding comes down drastically, about 80 to 90%, both at intermediate, secondary prophylaxis or whatever. So approximately 10 to 30,000 per person per year would be approximately useful and a ballpark figure to be able to take care of prophylaxis. So the guidelines suggest that solvent detergent treatment is the gold standard, and it will remove all infectious material, and similarly nanofiltration is the procedure of choice, and these are the kind of products that we should get in India. And even our own products, which is make in India, made in India, that sort of thing, it has to come to international standards so that we are getting our patients all safe products. So all currently licensed hemophilia treatment are given by IV infusion. They have to attend hospital and taught self-infusion. Majority of the people are seeing those factors. Recurrent venipuncture can damage all their veins and so on and so forth. And therefore subcutaneous administration of all these non-factor concentrates, non-factor options are much better because it's just a once a month and person's all right. And then of course we are going to start gene therapy in India soon. Clinical trials are already on and it should be soon available in the thing. And so once you have a gene therapy, it is getting closer, and how it will impact these products, I don't know, but it's a great times to be in India because all the treatment options will be available in the country. Thank you.
Thank you, sir. Now I request our chief guest, Dr. Harsh Mangala, Director, National Health Mission, to please address the gathering.
On this occasion, dignitaries present on the dais, President HFI, all the vice presidents, dignitaries present in the hall, all the treating doctors, health representatives from states, and also the warriors whosoever present in this hall. I welcome you from my side and from ministry side. And it has always been a pleasure to attend this conference. Last year also I attended, and maybe many people know because I am looking after Director National Health Mission for last more than two years now. So I'm looking after sickle cell disease also and thalassemia along with hemophilia in the umbrella name of hemoglobinopathies or blood cell in National Health Mission. So as many people might be aware that, states propose to us in National Health Mission some funds, whatever they can spare in their overall kitty, because National Health Mission is a fixed budget from Government of India side, and Government of states, they propose various proposals for NHM, including the blood cell proposals for sickle cell, for thalassemia, hemophilia, and that's why we are associated with states also for these diseases. And as Mr. Prem Roop has mentioned that till last year we were approving all the factor drugs, but there was a gap in our system because these drugs were not in essential drug list. So there was a technical issue that without being so, how we can approve them. So there was an effort on the request of all the states and all the interested participants that it should be added, and that's why we tried, and finally the drugs were added, and we approved the money to the states. I think in after the elections are over in June only we have released the approvals for the factor drugs. What challenges I saw, because this time probably second year it was a main exercise. I looked after how factor drugs are approved, how they are claimed from the state. So many difficulties we also face while we see the proposals of the state. So we see that general amount has been claimed by the states. There is no detail, there is no description about the patient's number. So I found that this sector can be improved a lot by bringing more transparency. As a person who is responsible for approving the amount to the state, if I find that one state is taking the amount at a certain rate and another state is taking the amount maybe at 10 times of the rate what state 1 has claimed, then it gives a sense of confusion to me that what amount is correct, which amount is correct. I understand that the drug administration depends upon various factors of patients, but can the variation be so large? So we tried this time to streamline. I could streamline it, but I am not 100% sure. For your clarity, I am not doctor, I am chartered accountant. So my mind goes in that direction, that how we can better the idea, better the proposal, and how we can clarify the things in minutely, so that not only myself, my superior officers are also clear that the proposal sent to their table is free from any ambiguity or free from any confusion. So we tried our best to clarify the things from the state. We took the number of patients first, and what number of units of doses or something like that they wanted to administer, and a certain rate we applied. So some clarity has come from last year, but I think we are at 60%, we are not at 100%. State representatives are here. I request them earnestly that they should also go in deep details that what they are proposing, and whether that number, unit, rate, whether that matches with the actual requirement and actual demand in the states. So this is one thing, and we will definitely improve next year, because we are in this process also we are trying to make up the database of how many, which year we have approved what number, so that there can be some correlation of the numbers, whether it is going down or it is going up or something like that. And there should be also a economics of scale also. Many times the rates of many things are increasing due to inflation, but in health sector many things are coming down also. It is not like that last year it was this much amount or rate, so next year it will be same, because many competitors are entering into the market. So we should cover more people. We discussed many times about the net testing. So net testing rate has been static for last 3-4 years. In my time, I have never seen any person who is claiming at the lesser rate. So whether it is possible that we can, because budget is limited, as I told you in the beginning, the reason to tell you was that budget is limited with the state also. State has to spend that amount in RCH activities, in health infrastructure, and some many more activities, and out of that very small portion is of blood cell. So if we can cover from that small portion more number of people, either for sickle or maybe thalassemia or hemophilia, it will be a great blessing for everybody. So maybe, you know, everybody here sitting from state or maybe some professionals, they need to see whether the amount can be, benefit can be spread out to more people by just bringing the cost down regarding the proposals. So this was the second aspect. Third aspect, that we are, as you might be knowing, that last year sickle cell mission was launched in July. So that portal was launched to register the all sickle cell beneficiaries or screened people. This portal was instantly also used to register the thalassemia patients also. Now, I tell you that more than 9 lakh people have been, who have been screened maybe in last year or maybe previous to that also. 9 lakh thalassemia patients database is on our portal now. And I have already told the NIC team to include the hemophilia portion also in that same portal, so that, you know, we can come to know how many hemophilic patients are there in the country whom we are either providing or supporting in any manner. So one portion is to registration or screening, registration and screening. Second is what is the follow-up. So in sickle cell, we are developing this follow-up module. So same will be applied to thalassemia and for hemophilia also. Like they are registered now, they are either carrier or they are deceased. So what benefit our system is providing to them, whether vaccination, if given by states, has been given to them, drugs being administered monthly, quarterly, whatever system is there, any blood test if they require, whether it is happening or not, blood transfusions happening or not. So, and counseling and awareness definitely for carrier and disease. So similarly, the follow-up module will also be developed for the all these 3 segments of hemoglobinopathies. I am sure when I am not there, maybe next year, after 2 years, but definitely this system will grow. I earnestly request that, you know, many times we hear this number, Mr. Prem always comes that, you know, these numbers are identified in the state. Maybe because of our lack of efforts also, you know, this number has never come very officially and a static number from the states. So only reason may be that we have never asked for also very seriously, but once this registry will be there, then we can officially convey to them that this is the number. If it is correct, please agree it. If it is not correct, please add whatever patients you are having. So I think this registry will be a very good step for the future. Many things are mentioned in the 2016 guidelines, but definitely some things need to be refreshed. There is a demand that, you know, we should also relook our things so that, you know, some new developments can be taken care. So we are very serious about it, and definitely we are thinking over it. And recently whatever you know, focus has come from sickle cell side, definitely it is also adding the benefits to the similar patients of other streams also. So I think this was the very small brief which we are working in the ministry, and definitely we are there to support in any kind, any manner. Only requirement from our side is that, you know, one more thing I wanted to speak, whether we give the you know, these drugs, we approve the drugs to the states, but many times there is complaint of non-availability, or one portion of state is given that drug, other state is not having that drug. So transport and transfers, all these issues are there. And many a times professionals also doubt, because these are costly drugs, factor drugs are costly. Professionals also doubt in government sector whether these are actually being used for the purpose for which they are being approved or sanctioned. I am not saying that these are not being used. I am not having any proof, but I am saying that there are chances of misuse everywhere. In every system, in every sphere, there are chances of misuse by someone. So how we can, you know, utilize, or how we can cross check whether, you know, the amount which has been given to the state, to the district, to the maybe health facility, whether it is being put to use in best manner. Any kind of maybe social check or social audit, can the federation or their chapters can bring some study or some report to us that, you know, this was the findings we had in the state. So these learnings will also help us, you know, to give feedback to the state. So maybe, you know, federation can think about it, that in cordial manner with the state government, without, you know, disturbing the main main objective of the social audit, how we can bring out the points of improvement and points of some corrections in the system. So that was my last point. With this, I can see many professionals here. I thank you also for being here and inviting me, and it is pleasure for me to come here and speak about it. Thank you.
Thank you, sir, for gracing us with your presence today and addressing the gathering, and for the unwavering support and thorough follow-up and assessment which have been instrumental in improving the care of hemophilia and hemoglobinopathies in India. We look forward for more support in the future. Now I will request Vice President Finance, Hemophilia Federation India, Mr. Jagdish Sharma, to please deliver the vote of thanks.
Thanks, Sonu ma'am. Today's our chief guest, Shri Harish Mangalaji, IAS, Director NHM, Ministry of Health and Family Welfare, Government of India. Sir, on behalf of the Hemophilia Federation India and the entire hemophilia community, I extend our deepest gratitude to you as the chief guest for gracing us with your presence today. Your support and understanding of the challenges faced by our community are truly invaluable. Your commitment to improving the health and well-being of individuals with hemophilia inspires us to work with even greater dedication. We are deeply grateful for your ongoing support and collaboration in our efforts. I am also highly thankful to mission directors, NHM, principal government medical colleges, disability commissioners, particular Shri Uma Shankar Sharma ji, NHM state nodal officers for their dedication and efforts in making this event successful. Special thanks to the doctors across the country who are tirelessly taking care of our person with hemophilia. Your dedication, compassion are the backbone of our efforts to improve the lives of with hemophilia. I express my gratitude to our chapter key persons, other stakeholders, media persons, and particular hotel staff for their hard work and commitment to ensuring the success of this event. I am also thankful to our President, Mr. Prem Rupalva, Vice President Medical, Mr. Sisal sir, Dr. Sisal sir, Vice President Development, Mr. Ramu Gadkarji, and the entire Executive Committee of the HFI, Shri Pawan Madhukar, CEO of HFI, for their unwavering support for the cause of hemophilia. Thanks.
We will now conclude the inaugural ceremony. We'll have a photo session now, and we'll be moving forward to the scientific sessions. Our first speaker today is from Government of Maharashtra, Dr. Chandrakala from KEM Mumbai, who will be speaking on need of multidisciplinary care in government setting. Leading the IHTC at KEM Mumbai, Dr. Chandrakala holds extensive experience in hemophilia management and research. Dr. Chandrakala also has many publications to her name. Under her guidance, numerous complex surgeries have been successfully conducted, and she plays a key role in the tendering and procurement of hemophilia treatment products in Maharashtra. Please join me in giving her a warm round of applause as she takes the stage. Welcome, ma'am.
It must be there. Yes, yes. So, good evening, everyone. First of all, I would like to thank HFI for inviting me to talk one of the very important topic in the management of hemophilia. We all have treatment centers. We need to upgrade our centers to multidisciplinary care settings. So in the next about 10-15 minutes, I'm going to talk what is multidisciplinary care, and I'm also going to show some of the cases which can be managed with the multidisciplinary care. So we all know that hemophilia is a very complex disorder to diagnose and to manage. You can see in this, patients you can see from starting with the pediatric age and the young adults, and even the patient as young as 10 years, you can see the deformity. So it requires a multidisciplinary care because it's a severe disorder and requires the treatment from acute bleeding to the chronic complications with the bleeding. So the other thing we always see in hemophilia patients is disability. This is one of the study which is conducted in 2007, but still our disability, nobody has done any data that how much disability has decreased after starting the free factor therapy, because number of patients who send prophylaxis only about 9%. So there is not a major difference which has happened. Unless we have a data, we don't know how much patients are disabled. This is from the Indian data. This is a study conducted in 148 patients. 139 patients are suffered disability. It's almost about 94% of the patients had disability, and only 9 PWH without any disability. And number of joints over 1 year is 72% of the patients had more than 6 bleeds per year, and our 75% of patients may only live up to. But now with the advanced treatment, we see patients as old as 60, 70 years patients also come for the treatment. And in the incidence of fractures also is high in these patients. So we see actually now more and more factors are available, and more hemophilia patients are using the bikes, and almost about 1 to 2 fractures per month we see because they use bikes, and history of fall and osteoporotic fractures are one of the most common complications we are seeing in hemophilic patients. So what is the importance of multidisciplinary care is comprehensive approach, where hemophilia requires you need to address the complex situation like a medical, emotional, social, all the problems. We are treating hemophilia as a together with the family. So that's a comprehensive care. Why you doing the comprehensive care is to improve the outcome. So to improve, there can be standard protocols are used, standard guidelines are used for the management of patients. So experts are actually specialized are come together for the management. And here in a multidisciplinary care, patient-centric approach. Patient will have a shared decision in the treatment of management, in the taking the decision regarding the treatment. Patients or family becomes a center in the multidisciplinary care. So comprehensive care we have is effective programs to integrated. We use the guidelines and the protocols to care for these patients, and the patients and the families are involved in this program. and tailor the management to individual patient needs. What do you mean by the individual patient needs is somebody is like a pediatric child, is not able to go to school, give them prophylaxis. And somebody is like, we see patients who is joined as a new job, the probation period of 3 months is there. Give them prophylaxis for at least that time. And somebody is going for exams, so adjust according to the patient's need and adhere to the guidelines and the standard protocols, regularly participate in quality assurance and consult with other programs. Like if the patient is hemophilic, it requires surgery, then we consult with the surgeon. So it's like a specialists come together to participate in collaborative research in these patients. So what is the use of multidisciplinary care is best health and quality of life outcomes can be seen with the multidisciplinary care, and prevention of bleeding and the bleeding complications are there because of the prophylactic therapy, prompt management of all bleeding disorders. Somebody comes with an IC bleed, it requires a surgery. So you coordinate with the surgeons, like a neurosurgery, and then you can get the surgery done. So that's how the multidisciplinary care happens. Emergency bleeding, example again, IC bleed. Patient comes to our ward, treat the patient first and then do CT scan. So it's already integrated. Protocols are very, very clear that these patients requires first factor, then do the CT scan. That's how the emergency care. And management of musculoskeletal, that's very, very important because majority of patients are not on prophylaxis. So musculoskeletal deformity is very, very common, and that also has to be taken into consideration. This is all managed in the multidisciplinary care. So what are the key members? This I put our own center's picture. What are the key members in the multidisciplinary care is patients and families at the center for the multidisciplinary care, and then the hematologist. See, hematologist just facilitates your care, but the nurse is a very, very important nurse. No, you tell nurse, this patient undergoes dental extraction. So she makes the dentist is there, factor is given. So this, hematologist guides them, but entire program is run by the nurse because she makes sure that patient gets the factor before any surgery. On time, patient gets evening, morning dose, or it's getting the factor. So the nurse is equally very, very important person in the management of hemophilia in multidisciplinary care. And the other problem is orthopedic surgeon, because majority of patients are on-demand therapy require like TKR, hip replacement, knee replacement, and musculoskeletal deformity. So orthopedician and the physiotherapist or an occupational therapist, depending on which one you have, so plays a very important role. And the laboratory is, without laboratory, it's very difficult to manage any surgeries in hemophilia. So lab person and the social worker these are the major people which we have in the hemophilia multidisciplinary care. This is our center, which we had inauguration of multidisciplinary care OPD. So along with our dean madam, so it's all our team from dentistry to the laboratory specialists, all of us there in this picture. So what are other members? So hemophilics can also have a hernia. So they can refer to a specific surgeon will be there. So you cannot refer to anybody, because everybody is not accustomed to management of hemophilia. So we have a specific hemophilic surgeon, specific dentist. So sometimes patient gets a dental extraction outside, they come with a shock time, That's why a specific person who takes care of hemophilia is better. And hemophilics also have hepatitis C induced liver cirrhosis. That's one thing we see. So that's why we hepatologists. And we also using a lot of gynecologists because BW patients, other factor deficiency are becoming pregnant. So we need to coordinate with them. So we have an OBG specialist. We had a women and bleeding disorders from London. They had come to us. So we had a meeting with them and how gynecologists playing a very, very important role in the management of women with the bleeding disorders. So that is what one of the things we have to have OBG specialist, geneticist, and psychological support. Without psychological support, it's very difficult. Last 15 days back, I had a patient who had come to me with 21 years wheelchair bound. He told me, I cannot lead my life in wheelchair. You have to do something for me. Even though he's inhibitor positive, we had to take him a surgery because he was so depressed that I cannot lead my life. So hemophilia A with inhibitors, you have to undergo hip replacement. Because psychologically also you have to see patients, like a lot of patients going to depression, so psychological support is very important. So psychologists also a part of comprehensive care. So benefits, You have communication. So any hemophilic center, hemophilia chapter can communicate us properly, and we can communicate with other doctors. Wherever is the problem, patient can be referred properly. Collaboration of other specialties is done with the multidisciplinary care. And continuity is not only once you are treated, you do a knee replacement. You can't let the patient go. At least for the initial 3 to 6 months, they have to come to the physiotherapy, take factor till they become mobile. You have to do a proper monitoring. And yearly once these patients maybe have to test for hepatitis A, hepatitis B, C, and HIV along with inhibitors. So these things can be done in a multidisciplinary care because of proper protocols are used. Bleeding management. Any bleeding patient has got, we have to manage the bleeding properly. Prophylactic treatment and self-infusion. These are the things which can be done better in the multidisciplinary care because you have a lab backup, because you can't do prophylaxis without the lab because we need to test inhibitors. Musculoskeletal care, it's a part and parcel of any hemophilia care. You cannot run a hemophilia care without a musculoskeletal specialist because they are in a day-to-day life is very important. Pain management, because all these patients are there to, like now more and more patients on prophylaxis, the pain threshold is coming down nowadays. So pediatric patient has a knee bleed, they have a more pain compared to an adult patient who has got pain. So pain management is very important. You can see here, it's our own occupational therapy department who has done the splint. It's because they can't afford from outside to buy. So our occupational therapists have they do splints by their own, like manually they do the splints. And below you can see patient undergoing the knee replacement. So these are all the coordinated efforts of different specialties who comes to the care of hemophilia patients. Again, addressing the psychosocial effects, problems also. Hemophilic, you can see many a time only the mother comes or only a single parent is there. So the psychosocial, the mother is the only earning member and she takes care of. So we have to make some facility for the mother. How can she do better, or how can we help her in a better way? So in that way, many of the hemophilic mothers have joined some of the other job where they can get the better treatment for the child, like ESIC facilities. So many of in our hospital only, maybe in the last 1 year, at least 10 mothers have started the ESIC. Somewhere they're working and they can get the better treatment for the child. So empowering the patients and the families by giving the self-treatment, self-infusion programs, and we always work with our women group in in Mumbai chapter. They do so many functions, so they empower the females. How can they improve the care of the child? So as such, multidisciplinary care gives comprehensive management of hemophilia as a whole total person with the family, and it's a patient-centered approach and continuous improvement. So we cannot stop at one thing. So initially we were only giving on-demand therapy. We went on to prophylaxis, then we went on to do surgeries, then we went on to give ITA. So that's a continuous improvement will be there in a multidisciplinary care in the management of hemophilia patients. So why in government settings we need a multidisciplinary care is, you can see in Maharashtra we had 9 centers in 2015. Now we have got all the districts has hemophilia. Factors are available. So, but still we get the patient from far off places to get a dental extraction, to get a surgery for priapism, to get a replacement. Because they travel for a simple dental extraction, they're traveling 12 hours. So it's really difficult. So why? That is the need. We need to have multiple multidisciplinary care centers in any districts. Maharashtra is being a big state, we need to have at least 2 to 3 multidisciplinary care centers where the patient don't have to travel 12 hours to get a simple surgery done. So that's how we can improve the multidisciplinary care in all the districts. So other thing is, this is from the Joseph John study. You can see the treatment centers in India is majority of them are government sectors. So it's the factors are provided in the government sector. So we should not end at giving the factors. We have to upgrade ourselves to doing small surgeries. Don't start with a hip replacement or knee replacement. Start with the small surgeries and then you can improve the care. So always the centers are there to help all the things. No? You can call up anybody, they will help you to procedure management, how can you do the management of these patients. So because government sectors, the majority of the treatment facilities are available in hemophilia, so we need to develop multidisciplinary care in government centers. Again, you can see here, this is from the, again, Joseph John data. Dental treatment and orthopedics is 12 to 13%. What is the problem? Everybody tells hemophilia patient not to brush their teeth, but nobody does the dental extraction. So that is very, very bad, no? Dental care is very, very important. Maybe we must have done 1,000 procedures for the last 10 years in dental only. We are wasting so much of factor because no proper dental care is advised. We don't have a dentistry or orthopedic surgeon in our multidisciplinary care, whatever we have in India. So we need to include dentistry as a part of management. Orthopedic surgeon should be a part of our program. That's the reason we need to have in government settings. Again, lab facilities also. So there are not of many labs which is doing the lab testings are not done. We do surgery, you can't do without inhibitors. We do prophylaxis, we can't do without inhibitors. Have a simple test actually, you can do screening, you can do it in your center, or do APTT, we know at least factor 8 or factor 9, that much is helpful for the management of these patients. Now I'll show some of the cases. This is the case of, you can see in the first picture, this is the case of hemophilia B with inhibitors. Maybe it's one of the very difficult case to manage, hemophilia B with inhibitors. He came to us in shock. He had a sepsis, he was pouring pus, he had multiple blood transfusions, nobody did surgery, he was roaming around all the centers because his B with inhibitors very difficult to manage. You can see the X-ray showing multiple osteolytic lesions. So with the support of HFI, patient body, hematologist, orthopedic surgeon, lab support, we could do this surgery. So this is the way we can collaborate. Multidisciplinary care is collaboration of all the things together. Because here, patient family went to multiple hospitals. We get support from even Goa Medical College also gets supported. Means so many, as far as so many centers gave us a Nova 7 to do surgery for this patient. The patient body played a very important role along with other specialists. So this is how you can come together to manage a patient of hemophilic. Now he is actually, we had to amputate to save his life. That's how we can manage the patient with the multidisciplinary care. So the other one is 19 years boy, hemophilia, and inhibitor negative. He had recurrent bleed in the joints and again had difficulty. When he came to us, father carried him. 19-year boy carried by a father. How bad. Father told us, at least make my son to walk. That is the only request he came to us. You can see how the joints in the initial stages. So then we had a serial casting, then patient underwent surgery, and you can see in the last picture, patient is walking. So this is a coordination effort of orthopedic surgeon, lab, and a occupational therapist. So multidisciplinary care is come together and have a better management of hemophilia patients. Why in government setting is the cost of treatment becomes tremendously less, and we have factors. No, we have factors, so we can do wonders for the management of these patients. Again, this is also one of the patient who came to us like 44 years male. He came to us hemoglobin of 3 point. Nowadays, we see a lot of patients of hemophilia coming with hematemesis and melena. Immediately, we can do the scopy, but this patient had come with hemoglobin of 3.4 grams, and he had a mild hemophilic history. We did a scopy. Scopy was showing a mass like a tumor, and the patient had to undergo surgery. So initially GI medicine played a role and GI surgery came into picture. So when we required GI surgery, they came into the surgery. So that's how we can do this patient underwent a surgery. So you can see the patient had a tumor in the abdomen, in the stomach, and underwent surgery. So this is a collaborative effort of lab, surgeon, and the hematologist where plays a wonders for the management of these patients. So again, the centers can teach self-infusion programs also. The nurse plays an important role. We can teach whoever are interested, parents or the patients can be given training for the self-infusion because makes them independent, not depending on the hospital or a treating doctor. They can infuse by themselves. That is how you can make hemophilic patients self-dependent, independent because they can get the factors. They can carry the factor, and this is how we train our patients, because multidisciplinary care will have a nurse, occupational therapist, so that we can take our patients. So with our multidisciplinary care, we could do this surgery, like this many surgeries we could do in our center this 2023. You can see the dental surgeries, 70 numbers. Like in 1 year, we had to do 70 dental surgeries. Endoscopies is 32 endoscopies we have done, and orthopedic surgeries 19. So with the use of multidisciplinary care, the patient, number of patients can get the proper treatment can increase, and this can be reduced in a tertiary care center so that other centers can take over this. Small surgeries can be taken over by other centers. So to conclude, the wide-ranging needs of hemophilia, people with hemophilia and their families are best met to the coordinated delivery of comprehensive care by multidisciplinary people or a staff team. And it should be accessible and available to all the PWH, if not every district, or at least few places, like in Maharashtra, maybe 3 to 4 comprehensive care center and multidisciplinary care center will help better management rather than coming to the one center. They have to travel a lot to one center because they have to stay in the hospital for about a month or so for a joint replacement, so they can get a nearby center. That is the whole idea of this talk, is to improve the care. Having small procedures can be done in your own respective places, and self-infusion training can be done. And at the end, one more word is prophylaxis is the only treatment which can change the natural history of hemophilia. In the next 20 years, if you want to reduce the number of surgeries, start prophylaxis now and make the patient independent with the musculoskeletal deformities. Thank you.
Thank you, ma'am, for the wonderful presentation. I now please request our President, Premrup Alva, to please felicitate Dr. Chandrakala on behalf of Hemophilia Federation India. Our next speaker is Professor Tulika Seth, AIIMS, New Delhi. Dr. Seth is Chairperson for Disability Guidelines for Blood Disorders, Gazette of India, March 2024, Chairperson for Ministry of Health and Family Welfare and MOTA 2022 for sickle cell disease. She serves on the board of NNHF with panel of Indian experts, drafted Government of India National Guidelines for Thalassemia and Sickle Cell Anemia 2016. She co-founded GAP Health for Dissemination of Genomic Awareness. She served as Delhi School of Public Health founding member and an expert board till 2023. Madam serves on various boards. So without further delay, I request her presence to the dais. Dr. Tulika Seth will be speaking on long-term prophylaxis with EHL factors and inhibitor management. The knowledge partner for this session is Nordisk. Welcome to the stage, ma'am.
So thank you so much, and I am very grateful to Hemophilia Federation of India and all of its executive body members, and I'm most of all grateful to all of you in this hall, and it's wonderful to see our community growing every year. So first of all, a big round of applause to all of you, right? Thank you. Now, the topic assigned to me is actually quite a lot. So, long-term prophylaxis with EHL, and inhibitor management. So, it's a lot of things that I am going to be covering, and I'll try and do this as quickly as possible. So, we all know that we have a large number of patients with hemophilia A and B in India, and if we compare it to many countries in the world, our population size is quite large, and unfortunately, it's growing as well. But the scene of prophylaxis in India is not so good. So though we have a large number of patients, the numbers of patients on prophylaxis is still very small. The low coverage of prophylaxis and home therapy leads to a lot of complications, which you are all well aware of. And that is something that we need to address. So why is it time to change? It's time to change because one, we have products easily available, the cost of products has gone down, there's much more awareness, and we have an armamentarium of different products so we can tailor it to different patients. Some patients have venous access problems, some patients live far away, some patients are doing well even with just plasma-derived factors. So we have various things. We have various goals also of the patients. So prophylaxis, why we need it, I don't really need to tell in this audience. We know, as Dr. Chandrakala just said, that on-demand therapy is not really standard of care. Sometimes we come across patients who are still a little bit scared of prophylaxis because they fear inhibitors. There are many studies now to show that patients who are on prophylaxis have less risk of inhibitor development. So this is something to remember, that it doesn't increase the inhibitor risk, it decreases the inhibitor risk. Patients will develop inhibitors if they have high risk mutations, and that has nothing to do with prophylaxis. Prophylaxis also helps to reduce your factor consumption. Why is that? Because if you have a very high ABR rate, each bleed will require treatment with factor, and it may be several days, maybe even weeks before that bleed is cured. If you're on prophylaxis, many patients are now on low dose prophylaxis. If you don't have a bleed, over time, your factor consumption is less. And if you have healthy joints, no target joints, you will not need large amounts of factor for surgery. We get a lot of patients from all over the country for 2 or sometimes even 4 joint replacements. So all of that will go away when we are using prophylaxis. And WFH guidelines has basically said that on-demand therapy is not treatment, and we need to do prophylaxis. In cost-constrained settings, we can think of low-dose prophylaxis. Primary prophylaxis is when we start the prophylaxis before the age of 3. That is the ideal way, but whenever you start prophylaxis, even in patients who we've started prophylaxis after joint replacement, even those patients benefit. So whenever you have the opportunity, it should be started. Now, how do we give prophylaxis? So earlier we only had standard half-life products. Now we have extended half-life products, and we also have non-factor products. So all of these options are there, and all of them are available to all the doctors and the patients, and we need to encourage our state to support these. So the conventional factor prophylaxis with standard half-life, everybody's well aware. In hemophilia A patients, it's given 3 times a week as an intravenous injection. In hemophilia B, we give it twice a week as an intravenous injection, and there's several different dosing regimens, but all of these are very good, and there is nothing wrong with standard half-life prophylaxis, either with plasma-derived or recombinant. So I want you all to go back with the message that we have many options, and all of these options are good. However, in some patients with standard half-life products, they may still be having high annual bleed rates, especially if they have target joints or very bad joint health. In those patients with joint disease, standard half-life may not be enough. So in those patients, extended half-life products can be very suitable. What we are doing with many of the ESI patients is that if they have target joints and very bad joints, we put them on extended half-life products, and we recommend good physiotherapy. With extended half-life products, the target joints can disappear, and with good physiotherapy, their joints may actually improve, and then we can put them back on the standard half-life products. So there's many options that we have that can tailor make the treatment that we have. Obviously, if you're using extended half-life products, the number of injections is going to be much less. And especially if you have a hemophilia B patient, because the products that we have currently for hemophilia B extended half-life, you can give once a week, once in even 10 days. For the extended half-life factor 8, currently the available products are better than they have a better half-life than the standard, but we don't have the very long extended half-life as yet, but that may come soon in the future. How do we make a product extended half-life? We can do pegylation, which is by adding a molecule, we increase the circulation, and most of the extended half-life products we have in India are pegylated products. So this is a very simple and safe measure, and there's nothing to be worried about by using these pegylated half-life products. The data from the pegylated half-life products show that if you're using a factor 8 product, your number of injections is less, your ABR is going to also be reduced, and so with less bleeds, you will end up with much less injections required to manage these patients. And similarly for the factor 9, again, you'll find that again, patients can have 0 bleeds and they can do really well. So over 70% of children with pegylated products, even with target joints, had zero bleeds. So with zero bleeds means that you don't need to give extra doses of product. And as I said, over a longer period, you will end up with much less target joints and better result in the joint health. The inhibitor risk of these is also not increased. Most of the experience of these have been done in patients who had been previously exposed. So extended half-lives are usually recommended, not in pups. Pups are the previously unexposed pediatric patients. And the similarly in factor 9, patients on extended half-life, again, you have very few annual bleeds, and these patients do very well, and they can have zero bleeds as well. So the overall analysis shows that there's no risk of inhibitors, there's no safety concerns, there's no risk of thrombosis because some patients were concerned about that. And so we can see that there's a lot of safety things that are there. Now, cost effectiveness, we know that the per unit cost of the extended half-life products is more. And that is something that we have to talk to administrators about, because even though the per unit cost is more, you are using less of the product over years. And that is very important to know, because that will save money in the future. Many of our patients are also a little bit overweight. And there's a lot of concern about whether we should dose patients as per their real weight or as per their ideal weight. And there's some very good data to show that you don't need to dose as per real weight, because many patients are obese. And in these patients, if you dose them as per their ideal weight, they will have good control of their bleeding, as well as it will be cost saving. So this is something that has come out, and you can end up with significant cost saving over a longer period of time. So this is just something I wanted to share. We can also individualize the prophylaxis. There are some patients who have less bleeding rates. Some patients can be given less injections or less dose, and that way you can tailor make it. And there will also be some patients in your OPD who might need higher doses, so that way you can balance it out. Now, we don't always need more things. I know a lot of times we just keep going to the government and asking for more, but there's data to show when prophylaxis was given with the high dose and compared to the intermediate dose prophylaxis, there was actually no difference in either the joint rates or the bleeding score, but the cost of high dose was much more. So at AIMS, for our reimbursable patients, we put them on the intermediate dose, and now we also have a lot of good data from India about low dose prophylaxis. Low dose prophylaxis, again, we should collect all the data because we don't have 10-year, 15, 20-year joint health data on that, and that's why at the moment for our reimbursable patients, we are using the intermediate dose. The availability of factor is always an issue because of the large numbers of patients we have, and that's why I think it's important that we have all the different products available so that we are able to give something to our patients rather than saying that, okay, we don't have one product or we don't have another product and we can't give you what is required. So with this prophylaxis, we can really help the patients, and we need to make sure that we have regular factor replacements for all of our patients, and this will prevent them from getting disability and allow them to reach their full potential. So there's some cases. This is just a patient that we had who was 15 years old, and he's about 43 kg. And he had been diagnosed as a child. He did have a very high ABR rate of 24. And this was because he had had very bad joint health. And he had target joints of both his knees and was frequently coming to the hospital with bleeding and pain. And he'd actually had to stop going to school because of all of these problems. And he was needing extra doses of factor on top of the factor that he was getting. The standard half-life products were given, but he still had bleeds, mostly because of the target joints that he had. So target joints often will not be controlled by the standard product prophylaxis, because in standard half-life products, we are keeping the trough level around 1%, but these patients need a higher trough level. And this patient was then subsequently put onto a long-acting product. And with the long-acting product, obviously not immediately, but he had good adherence. And within a few months, his target joints reduced. And over time, he had 100% resolution of his target joints. And this, he was also given a lot of physiotherapy. And we were able to improve his quality of life and have him resume his school and other activities. Now, in cases of surgery, we can also think of extended half-life products. This was a patient who had a very large pseudotumor. It was over the thigh, and he was fortunately inhibitor negative, and the patient was planned for surgery. And for the surgery, we were giving him the extended half-life factor 9. It was given on day 0, and a second dose was given on day 5. And no additional factors or anything were required. And we were able to, with a very low amount of the extended half-life factor and only 2 doses, take him for a major surgery. So this shows the ease of doing surgery with extended half-life products. When we are using standard half-life products, you have to give the product every day. We usually also have to measure the factor 8 or factor 9 level because sometimes it can go high, and it makes it a lot more easier to manage. So these are just some pictures of the surgery, and it was patient was discharged easily on day 7. So the extended half-lives definitely have a lot of benefit, particularly in those with target joints and in surgery, those with venous access, because if you're giving an extended half-life product, there are many less injections that are required in a year. So even if you're using a standard half-life factor 8 compared to an extended half-life factor 8, you're having 50 less injections in 1 year. So there's definitely a lot of benefits. And so this shows that we have many different products, including standard half-life and extended half-life. Now, when inhibitors happen, we have to change course because now none of the factors are going to work, even extended half-life. Sometimes I get questions from patients that if I have an inhibitor, can I use an extended half-life? No, you can't. None of them are going to work. So why do inhibitors happen? We know that they're alloantibodies. It's due to the different immune reactions in our body. It's a T cell dependent event. And we know that we can sometimes predict this in families, especially if they have a family history of inhibitors or if they have high mutations. And if you have a low responder, low titer inhibitor, you may be able to manage a bleed with higher doses of factor 8. But in any inhibitor patients, if they're going for surgery, then you should only use bypassing agents. And of course, if you have a high titer or high responder inhibitor, you only need bypassing agents. At the moment in India, we have recombinant factor 7A and APCC for treating bleeds in inhibitor patients. We also can take some of these patients for immune tolerance induction, but that's a very challenging and long-term commitment. So some families may be willing to go for it, some families may not. If they're willing to do it, the WFH recommends that inhibitor patients should be offered ITI because that's the only way you can convert an inhibitor patient back to a non-inhibitor patient. And we've done ITI at our center, and all of our patients who have completed the ITI, they are all non-inhibitor patients and back on their regular prophylaxis with factor 8. So the bypassing agents means that even if you have a factor 8 deficiency or a factor 9 deficiency patient, you're not going to treat them with factor, you're going to have to use these bypassing agents. APCC is available in our country. The usual dose to control a bleed is 85 units per kg. It has a longer half-life, so you can give it once or twice in a day. Recombinant factor 7, an excellent product, but often you will need to give multiple doses to control a bleed. And the half-life is only about 2 hours. So that's important to remember because sometimes we have patients with very serious bleeds and people have given 1 dose of recombinant factor 7 and then 24 hours later they're wondering why there's a problem, but the drug is only going to work for 2 hours. So there is a study where they've compared the efficacy of controlling a bleed and they found that 2 doses of recombinant factor 7 is equivalent to 1 dose of APCC. So it's important to understand that if you have a patient with inhibitors and they have bleeds, some of these bleeds are very serious bleeds, and you will also need to make sure that you dose them appropriately, and you do the frequency of the replacement appropriately in order to manage a bleed. So if you have major surgery, you need to make sure that you're giving the recombinant factor 7 every 2 to 3 hours, and you need to do it for several days. Similarly, if you have any bleed in the danger areas like the throat and neck, these all need to be treated very appropriately. Otherwise, a bleed in an inhibitor patient is very, very serious. And unfortunately, during COVID, we lost several of our dear friends who had inhibitors. When you're doing surgery, we prefer to use APCC because it has a longer half-life, and particularly in government centers, it's often difficult to make sure that everything is given appropriately. And it's, if you miss a dose of recombinant factor 7, it may be an issue. But both of these bypassing agents are important, and all centers should actually have both bypassing agents. The reason is because some patients respond better to recombinant factor 7A and some patients respond better to APCC. So having both of these products there is very good. We tend to use APCC more for our surgeries, and this is very safe and gives us very good hemostatic control, and often no extra doses are required. So these are the two products that we have, and both of them have advantages, disadvantages. Recombinant factor 7, because it has such a short half-life, you can give multiple doses. If you're using APCC, we don't recommend using more than 200 units per kg in a day, because otherwise you might get a blood clot. And the safety of both is definitely available. And if you have, so there is also some data to suggest that the hemostatic potential of recombinant factor 7 is slightly more for resolution of joint bleeds at several different hours. So these are some studies that show that. But again, as I said, there are a few patients who respond better to one product versus the other. But we're very fortunate that we have both of these products, and inhibitor patients, these are life-saving. The recombinant factor 7A is very useful, and it's even been approved for home therapy. It's easy to reconstitute and easy to administer, and it has a smaller volume, so it's very useful. So often most of the emergencies and clinics will have that. If you're using APCC, then that has to be given by a slow intravenous infusion, and it's never given at home. It should only be given in the hospital because there are other coagulation products there, and you may have reactions to that. If you're using a non-factor product as a prophylaxis, so in an inhibitor patient, they might be on emicizumab or other prophylaxis. In those cases, recombinant factor 7A is considered to be safer because there is a risk of thrombosis when you're using a non-factor product and you're using APCC. So this is something, again, to just keep in mind. And so it's, again, important that we have both. We have many things that we can give to our hemophilia A and our hemophilia B patients. So for hemophilia A patients with inhibitors, we have emicizumab that we can use, so that's very important. At the moment, for hemophilia B patients, we don't have any alternatives for prophylaxis. We would be treating these patients on demand for their bleeds. So as I said, we have many options. For patients without inhibitors, we have all these factors available, both standard half-life and extended half-life. We have emicizumab also for non-inhibitor patients, as well as for inhibitor patients. And there are many new products in the pipeline, so it's a very exciting time for us. For hemophilia B, we have both plasma-derived factor 9. We also have extended half-life factor 9. And though we didn't have any non-factor product for them, but the newer non-factor products can be given in hemophilia A patients and hemophilia B patients, as well as those with inhibitors and without. So with that, I'll end, and thank you very much.
Thank you, ma'am, for the very informative session, which helps bust myths about inhibitors development and for the insights on inhibitor management. I I request our Executive Committee member, Sri Samar Singh, to please felicitate Dr. Tulika Seth with a token of love. All of you, please join me in giving Dr. Tulika Seth a big round of applause. We are expecting with us Minister of States, Sri Prataprao Ganpatrao Jadhav, Ministry of Health and Family Welfare very soon. So we'll be waiting for him very soon. He's on the way, almost near here. In 2 minutes, he'll be here in 2 minutes. We'll be continuing the scientific sessions after that small session with the minister, sir. Yes, sorry for the small confusion. The minister will be joining us soon. We'll be continuing with the scientific sessions. With us, we have now from Government of Karnataka, Dr. Meera V. from Bangalore Medical College and Research Institute. Dr. Meera will be speaking on establishing services for hemophilia care, the challenges and solution. Dr. Meera V did her MBBS DCH Pediatrics, DNB Pediatrics, DM Hematology, is currently the professor and head of clinical hematology BMCRI. Presently, she is the head of the Clinical Hematology and Center for Coagulation Disorders and Comprehensive Hemophilia Care. It is also the nodal center for the hemophilia program in Karnataka state. She has numerous publications to her credit and actively participated in academic and research activities. Please join me with a warm round of applause as she joins the stage.
Good evening, everybody. I thank HFI for giving me this opportunity to share my experience. And I won't take much time because there's a lot of things happening all around us. So I think we all understand the basic fundamental requirement to start the hemophilia service is a budget, a suitable budget. And that is why we are all here. Year on year, we are trying to improvise ourselves because now the government is committed to hemophilia care, and there is a committed budget which definitely needs further improvisation. So, and once there is a committed program, the final target should be to have a comprehensive hemophilia care setup with multidisciplinary care facilities, which the previous speakers have already discussed in detail. So what is the reason that a comprehensive hemophilia care setup should be present? Because the optimal management of hemophilia is more management of care of these patients beyond a treatment of acute bleeds. So this improves the quality and the overall health of the hemophilia patients and leads to prevention of bleeds and also better management of the complications and prevention of the hemophilic prevalence itself, the prevalence of hemophilia itself. The slide is not moving. Yeah. So whenever there is a plan to establish a hemophilia service, initially the aim should at least be to have a facility for treatment, basic factor infusion, and to have some kind of a lab service to where you can begin with having services for PT, APTT, and inhibitor screening, eventually scale up to inhibitor assays and further specialized tests. Facility for reasonable level of rehabilitation and physiotherapy, and patient and family counseling, and at least capacity to do at least some emergency surgeries, and eventually scale up to have a complete comprehensive setup with facilities for advanced treatment facilities, physiotherapy rehabilitation, genetic counseling, psychosocial services, and molecular diagnosis, and also facilities for training. And it is essential that at least there is one center in each state with these capabilities. So at every step when we are trying to establish the services for hemophilia care, close coordination between the clinical team, the regulatory authorities, and the patient organization goes a long way in having a smooth delivery of the services and having a better impact on the patient welfare. And the essential requirements to start the service is, as we all know, budget, allocation of resources, and infrastructure to begin with, including space. So especially now the theme is to have a daycare service, dedicated daycare service. So infrastructure requirement is very crucial to have a good hemophilia service, and adequate manpower, which is dedicated for hemophilia care. And with all this, having the right and safe and efficacious product is very important. So for that, a sound procurement policy and a good supply chain is very important. And to smoothly orchestrate all this, good, a solid standard operating protocols is desirable. So we come to the next most important thing after the budget and infrastructure, that is selection of a suitable product. I think the VP Medical has already dealt in detail with this. So whatever product we choose should be safe, efficacious, and of good quality, or else all our efforts will be futile and we will not be able to improve the quality of life of the hemophilics or give them adequate health. So what are the challenges with this? So I think there is, the previous speakers have spoken about it, and there's going to be further talks on this. But in brief, in a nutshell, our procurement policy should have adequate provision to make all the available factor products available in suitable quantities. So it should include factor VIII, and a small portion of this factor VIII should be reserved for those with von Willebrand disease, the factor IX, factor VII, APCC, and non-factor therapies. And essentially, there should be no gaps in the factor availability. So it is futile having a product which is of good quality, but not available in enough amount if the supply is not continuous. So all of our efforts will be futile. And coordination with all the key stakeholders is very important in this. And also extended half-life products are very useful. I think Dr. Thulika has already spoken about it. It is quite useful and cost-effective to use these products during surgeries, major bleeds, and almost every clinical scenario, especially in those who are already previously treated. So what is the beginning point to establish a service? There should ideally be a dedicated day care center, because this center will be able to cater to the patient needs better, and the care becomes more patient and family centered. And the roles and responsibilities of the various key persons involved is very important. It should be defined, and having a sound data collection mechanism is very important, because data is very important for everything, to continue the patient care, to give suitable data for government audit, to ensure the further availability of factors at every and to have a registry. Data is very crucial at every stage, and it should our initial vision to establish the hemophilia care service should provide suitable provision for data collection. So what is the basic human resources that is ideally required to have this dedicated comprehensive hemophilia care services? Suitably trained clinician, nurse coordinator is the central person who will work in coordination with the clinician, and adequate facilities. A trained physiotherapist who has been exposed to hemophilia physiotherapist is very important, because physiotherapy is as important as factor therapy in ensuring that the hemophilics quality of life improves. And psychosocial support is very important, and a good diagnostic service which can suitably support the hemophilia treatment is equally important. And along with this, it is important to scale up and provide multidisciplinary care, and at least initially emergency surgeries should be provided. Eventually, we should be able to conduct elective surgeries and joint replacements. So what are the current gaps in delivering all these things? I think there are still large number of patients who are not diagnosed, and there are a lot of gaps in the diagnostic facilities. The uninterrupted supply of clotting factors is still not ensured. Majority of our patients are on episodic therapy, and disability is still rampant. And many of the facilities have, most of the districts have some infusion facilities, and they are still not comprehensive. And there is lack of awareness at multiple levels. To begin with, it is the patient himself, the treating physicians, and the administrative officials. So, and there are many myths about the risk of inhibitor developments. A lot of people are averse to taking prophylaxis. There are many roadblocks before we can eventually give home therapy, and there are administrative hurdles. There are financial constraints still, even though it is a program, and there is no, those with inhibitors and hemophilia B patients, many a time, sometimes they take a back seat. And what are the roadblocks further when you're trying to establish a more comprehensive care setup? There is need for more training and education of the health care providers, and there is geographic disparities and access to care. What facilities are available in Tier 1 cities, and the state capitals may not be there in the remote districts. So the care should be uniform even in the last mile. So that is the aspirational need. And there is variability in the quality and consistency of care. So the manpower constraints should be addressed by more enhancing our training capabilities and enabling the various treating doctors at each and every district and empowering them to give a better hemophilia care. Documentation is the most important thing when you are delivering hemophilia care. Each and every factor vial is very expensive and has to be accounted for. So this accurate data is needed for treatment planning and monitoring, and electronic health records have to become the norm, which will go a long way in improving the data collection. And also this data can help in furthering research and advancement of hemophilia care. So this is, I think most of the government hemophilia centers have this treatment records where all the vials are accounted for. This is the minimum set of data that each and every treatment center should have, so that there is uniform and better accountability. With respect to the treatment, there is a lot of confusion how to treat, what dose to give, because many a time the patient is more empowered than the doctor. He tries to dictate how much and how long he has to get treatment. So the doctors should be aware of the treatment guidelines, and also, as already discussed many a time, these doses are not etched on stone. It is not like an antibiotic dose. You can individualize the treatment dose depending on how advanced and how severe the bleed is, and where is the site of bleed. For example, in most centers, if there is an intracranial bleed, we go for a non-resource constrained dose. We give them, start with 100% correction. Whereas if the patient is presented with the early joint bleed, we can get away with a resource constrained small dose. So you have to individualize the treatment, and also the duration of treatment is equally important. There is much more confusion regarding that. When you're treating an intracranial bleed or a major bleed, like a spinal or a ophthalmic bleed, you are not supposed to stop as soon as you see initial resolution. You have to give it for adequate duration as enshrined in the guidelines. Whereas if for the routine joint and muscle bleeds, once the patient is feeling better, you can stop the treatment. And equal emphasis should be given on the price strategy, and early treatment is very important. If the patient comes to you with aura-like symptoms, you should not dismiss it and say you're just faking it. That is the best time to treat the patient. And early treatment and appropriate dosing should be given. And also the right CFC for the right patient is equally important. And this goes a long way in improving their joint and overall health. So I think the previous talk has covered in detail about the treatment of patients with inhibitor. But this is one of the challenges we commonly face. There is little data to guide the clinical management decisions in patients with inhibitors. And So also with prophylaxis, and now we have a basket of products even for prophylaxis. You have standard half-life products, EHL products, and non-factor therapies. Which patient to be put on which product there is a lot of confusion regarding that. And home therapy, especially in hilly areas, remote areas, is badly needed, and suitable government policies regarding that is still yet to be put in print. And newer molecules are further added to these challenges. There is confusion whether we should have a fixed policy or it should be based on the bleeding phenotype. With the advent of these newer agents, newer confusions have increased, even though it has really had a remarkable impact on the patient's quality of life. There are challenges accompanying their use in various settings, like what is the optimal dose, and which patient to be put on which product. Their lab monitoring is different, and facilities have to be scaled up in our country to address that, and how to address their breakthrough bleeds, and in case of any adverse events, what should be the course of action, and their cost is also a concern. And we have spoken about the product selection and the importance of having the whole range of products. The next challenge is to distribute it appropriately so that the factor is available across the state and across the country, and proper distribution helps in maintaining effective and timely treatment. It should be done according to the data available from each and every district. So if there are some, for example, in our state, we have a couple of districts where the incidence of factor 9 is much more than factor 8. And in some districts, the von Willebrand patients are much more in number. So the amount of factor we send should be based on the data which has been provided from that district, and not based on the general guideline, where you sent 80% factor 8 and 10% factor 9. It should not be on a fixed ratio. It should be real time based on the data that has been provided from those districts. And so this issue of the geographic accessibility is still there, and importance of having localized care in each and every nook and corner of the state and country is very important. And there are still, this is one area where a lot of needs to be done. For example, in our state, we have a policy where the capital, the nodal center, we place about 40% of the product, how much ever is available. 10% is there with the administrative, the logistics corporation, and the remaining is distributed to the districts. So when when you feed it into the Excel sheet, that itself provides gives calculations how much to place where. And we have all this data from the NHR. We know how many patients are there in each district. Accordingly, we plan the distribution, and it is suitably distributed in each district. And in case the product is over in one place and it is available in another district, there is also provision for redistribution. And towards the fag end, what is available in the nodal center is again redistributed across the various districts. And with such a mechanism, for example, if there is a critical bleed, let's say an intracranial bleed in the northernmost part of the state, he can receive the first dose in his district even before undergoing a CT scan, and he can be transferred in an ambulance. On the way, he can receive one more dose in some other district and then land up in the nodal center. So he'll be in a good state when he comes to the nodal center, and he can receive the further care in the nodal center. So suitable distribution policies helps us streamline care and deliver better care, especially in emergency situations. So in all these things, the role of patient support and importance of patient education and support services is very important. These patient support programs helps empower the patients with information, and also helps them take better self-care and take informed decisions about their personal life, prevention strategies, and also helps deliver better counseling services and psychosocial support to them. So patient advocacy activities go a long way in strengthening the care setup. So for each and every of these problems that the challenges that we face, it is important to have collaborative solutions and innovate the solutions sometimes, because the solutions may not be straightforward in each and every scenario. So our aim is to have comprehensive care. Yeah. The comprehensive care set up in each and every district to have access to prophylaxis and home therapy. And having a good policy in place helps deliver better care in emergency situations, improve the chronic health, and also improve the psychosocial and good quality of life to these patients. And the multi-stakeholder partnership is very important to deliver this. And also telemedicine and AI support helps us better deliver all these cares. So the key message is, it is important to envision and plan comprehensive care setup in at least 1 or 2 in every state, and address the challenges with collaborative and innovative solutions. And the role of patient support and education is very important, and multidisciplinary and multi-stakeholder partnership is very crucial in this. Thank you.
Thank you, Dr. Meera, ma'am. Now I request our executive committee members, Mr. Natraj Selvaraj, to please felicitate Dr. Meera V with a token of gratitude. Please give a huge round of applause to our speaker. The minister's arrived, and he'll be joining us in 2 minutes now. I request you all to please be silent and be standing when the minister is arriving. He's near the entrance now.
मिनिस्टर साहब 2 मिनट में आ रहे हैं. आप सभी अपनी जगह पे खड़े हो जाएंगे. जब वो आएंगे हम उनका एक प्यारा सा स्वागत करेंगे.
Ladies and gentlemen, esteemed guests, it's my honor to introduce a distinguished leader, an advocate for progress, and a true servant of the people, Shri Pratap Rao Ganpat Rao Jadhav, Honorable Minister of State for Health and Family Welfare. With a career dedicated to public service and a vision for a brighter future, Shri Jadhav has consistently demonstrated his commitment to the development and well-being of our society. As a key figure in our government, Mr. Jadhav has championed numerous initiatives aimed at health. We request for his continued support for our aim, one country, one treatment.
दोस्तों, आज हमारे बीच एक ऐसे नेता मौजूद है जो सच्चे मायनों में जनसेवक है, मंत्री श्री प्रताप राव गणपत राव जाधव साहब. जनसेवा के प्रति अपने समर्पण और एक उज्जवल भविष्य की दृष्टि के साथ श्री जाधव साहब ने हमेशा हमारे समाज के विकास और कल्याण के लिए काम किया है, चाहे वो इंफ्रास्ट्रक्चर हो, हेल्थ केयर हो, एजुकेशन या फिर इकोनॉमिक ग्रोथ हो। जाधव साहब ने हर क्षेत्र में सुधार के लिए बहुत सारी पहले की है। उनकी सोच और मेहनत की वजह से हमारे देश में कई सारे सकारात्मक बदलाव लाए गए हैं। श्री जाधव साहब का नेतृत्व, उनकी अटूट प्रतिबद्धता, नई सोच और लोगों की ज़रूरतों की प्रति गहरी समझ, इन सब से समावेशी है। उन्होंने अपनी पारदर्शी नीतियों और समावेशी दृष्टिकोणों से सबका दिल जीता है। आज प्रतापराव जाधव सर हमारे साथ है और हमें उनके साथ कुछ पल वक्त बिताने का मौका मिला है। उनको सुनने के लिए, उनके विचारों को सुनने के लिए, उनके भविष्य के प्रति विचारों को सुनने के लिए हम सभी आनंदित और उत्साहित हैं। तो चलिए दिल से स्वागत करते हैं माननीय मंत्री श्री प्रतापराव गणपतराव जाधव सर का।
Please join us with a huge round of applause as our President felicitates and honors our chief guest. I request our Vice President Development, Sri Ramu Gadkarji, to please deliver the welcome address.
नमस्कार, परत एकदा मी सर्वांचं स्वागत करतोय। वापस से एक बार मैं सभी का स्वागत करता हूँ। माननीय मंत्री प्रतापराव जाधव सर का स्पेशली मैं धन्यवाद कहना चाहूँगा। जब मैं बुल्ढाना गया था उनको मिलने के लिए, वहाँ के पेशेंट्स को लेके उनके रैली में गया था, तो उन्होंने वहीं पे कहा था कि मैं आपके प्रोग्राम में पक्का आऊँगा। ये पहले मिनिस्टर है, मैं कहना चाहूँगा यहाँ पे इनका कल आना था, बट उन्होंने एक दिन पहले आ गया है। इसके लिए एक बार ज़ोरदार तालियाँ होना चाहिए क्योंकि मिनिस्टर नॉर्मली लेट आते हैं, बट ये अर्ली आ गए क्योंकि हमारा हीमोफीलिया का दर्द उन्होंने समझा है। हमने बुल्ढाना में 2 दिन थे उनके कॉन्स्टिट्यूएंसी में, वहाँ पे उनको हीमोफीलिया के बारे में बताया। फिर प्रेसिडेंट प्रेम सर ने भी हीमोफीलिया के बारे में बताया, तो सर थोड़ा सा ज़्यादा सेंसियस होकर तुरंत हमारे प्रोग्राम को आने के लिए हाँ का मैं धन्यवाद कहना चाहूँगा। जिया जी और प्रोग्राम जी जो उनके मतदार संघ के हैं, जो सर के पीछे से लेके उन सर को लेके आ गए। आप सबका भी वापस से मैं स्वागत करता हूँ इस ISC 8 के अंदर, और मैं रिक्वेस्ट करता हूँ प्रेम सर अपना हीमोफीलिया फेडरेशन के बारे में बताएं। थैंक यू सो मच। नमस्कार।
Good evening all. Namaskar sir. And on behalf of 29,000 hemophilia and all the states, all the treating doctors and program officers, I welcome you for this meeting sir. A Hemophilia Federation India is a 40-year-old organization. जब हम बचपन थे उस टाइम हम सोच रहे थे सर that हम अकेले हैं, कोई we didn't know anybody else, एक और हीमोफिलिक पता नहीं था। उस टाइम हमारा एक फाउंडर है जो खुद हीमोफिलिक है, अशोक वर्मा जी बोल के, वो हीमोफिलिया फेडरेशन इंडिया, he established it in 83. And thanks to him that we have come a very, very, very long way, sir. हमारा ट्रीटमेंट पहले सिर्फ खून में हो रहा था, उस टाइम बहुत प्रॉब्लम्स था, HIV, HCV, एड्स, बहुत लोग जो हमारा हीमोफिलिया फेडरेशन का स्टार्ट किए हैं, we have lost them to blood disorders, blood diseases. But now the time has changed. Thanks to the government of India and all the states, हमारे पास products है, हमारे पास बहुत कैपेसिटी है, हमारा डिफिशियंसी है सर, डिजीज नहीं है। जो हमें जो प्रोटीन चाहिए वो मिल गए तो स्काई इज द लिमिट। डॉक्टर्स बन सकते हैं, पायलट्स भी बन सकते हैं। सो वी हैव अ लॉट ऑफ होप दैट गवर्नमेंट ऑफ इंडिया आई नो इज गोइंग टू कंटिन्यू सपोर्ट, मगर थोड़ा देयर इज लिटिल बिट ऑफ अ डिफरेंसेस। कुछ स्टेट्स बहुत अच्छे कर रहे हैं, कुछ स्टेट्स कैन इम्प्रूव अ लॉट, और थोड़ा कंफ्यूजन है बिकॉज ये MBBS जब पढ़ते हैं हीमोफिलिया के बारे में सिर्फ एक पैराग्राफ होता है, ज़्यादा डॉक्टर्स बोलते हैं, आई मीन ऑल द डॉक्टर्स हियर कैन सेकेंड दैट, मगर इतना डॉक्टर्स इन्वॉल्व हैं हमारा मूवमेंट में कि 20 साल 30 साल से इन्वॉल्व है। तो इसलिए हम लकी है, एंड आई कीप थैंकिंग ऑल माई डॉक्टर्स फॉर giving us a real life. So we are very fortunate. But abhi there is a simple problem. Treatment available, all states. Okay. And diagnosis is available in some states, but there is little bit of a confusion कि एक कितना मांगे, क्या करे, PIP में कैसे मिले. So उसके लिए हमारा ही डॉक्टर्स, गवर्नमेंट डॉक्टर्स का, आपका ही डिपार्टमेंट का, नेशनल एंड गवर्नमेंट डॉक्टर्स का एक स्मॉल कमिटी बना के एक गाइडलाइंस बना दिया तो ऑल कंफ्यूजन विल बी क्रिएटेड सर. So requesting you on behalf of everyone to, under your leadership, a guidelines banaya to, it will be very useful for the community. Thank you so much.
May I request our esteemed guest to please address the gathering.
मंच पर उपस्थित अभी नहीं, लेकिन श्रीमती आराधना पटनायक, MD नेशनल हेल्थ मिशन, श्री हर्ष मंगला, डायरेक्टर नेशनल हेल्थ मिशन, श्री प्रेम रूप अलवा, प्रेसिडेंट एवं हीमोफीलिया फेडरेशन के सभी जिलों के प्रतिनिधि एवं देश भर से यहाँ एकत्रित हुए डॉक्टर्स और अन्य गणमान्य, आप सभी को मेरा नमस्कार. मुझे यह बताते हुए गर्व महसूस हो रहा है कि हीमोफीलिया फेडरेशन 1983 से हीमोफीलिया रोगियों को देखभाल प्रदान करने के लिए अथक प्रयास कर रहा है. जैसा कि आप सभी जानते हैं, फेडरेशन अपने चैप्टरों के माध्यम से 87 जिलों में हीमोफीलिया के मरीज के लिए काम कर रहा है. फेडरेशन न सिर्फ उजागर हो चुके मरीजों के इलाज के लिए, बल्कि हीमोफीलिया के नए मरीजों की पहचान पर भी फोकस करता है, जिससे उन्हें सही समय पर उपचार दिया जा सके. फेडरेशन वास्तव में बच्चों को दर्द और विकलांगता से मुक्त रखने के लिए अपना योगदान दे रहा है. मैं बच्चों को विकलांगता से बचाने और रोगियों को अच्छी देखभाल प्रदान करने के आपके प्रयासों की सराहना करता हूं. मुझे आशा है कि आपका फेडरेशन हीमोफीलिया के प्रति लोगों को जागरूक करने का कार्य इसी प्रकार करता रहेगा. मैं आपकी यह भी अवगत करना चाहूँगा कि इस विषय में आपके द्वारा दिए गए सुझाव भी मेरे संज्ञान में हैं एवं मैं उन पर सकारात्मक कार्रवाई करने का पूरा प्रयत्न करूँगा. एवं मुझे विश्वास है कि आप सभी के सहयोग से हम न केवल अज्ञात हीमोफीलिया वाले व्यक्तियों का पता लगाने में सक्षम होंगे, बल्कि हीमोफीलिया वाले व्यक्तियों, उनके परिवारों और चिकित्सा बिरादरी को हीमोफीलिया देखभाल के बारे में शिक्षित और उचित जानकारी प्रदान करने में भी सफल होंगे. आज यहाँ पर आने के बाद में मुझे जो यहाँ पर हीमोफीलिया के बारे में जो जानकारी अभी सभी यहाँ के सभी डॉक्टर्स लोगों ने, आपका जो यहाँ पर संगठन है, संगठन के पदाधिकारियों ने, और जिनके घर में ऐसे मरीज है उनके घर के लोगों ने भी जो बातें यहाँ पर बताई, सही मायने में इसके लिए भी सरकार के तरफ से उनका कहना है कि कोई गाइडलाइन आना चाहिए. और निश्चित रूप से ऐसी बीमारियां है कि जिसको अच्छे लोगों को भी समझो हो गई तो उसको विकलांगता या उसके भी आगे की जो स्टेज होती है वहाँ तक भी उनको जाना पड़ता है, और उससे सिर्फ मरीज ही नहीं तो घर के सभी फैमिली के लोग उससे परेशान रहते। निश्चित रूप से आपके संगठन के लोग और हमारी जो ब्यूरोक्रेसी है, हमारे डिपार्टमेंट के जो लोग हैं, अधिकारी है, हमारी काउंसिल के लोग होंगे या हमारे मंत्रालय के भी सभी लोग होंगे, तो ये लोगों से चर्चा करके निश्चित रूप से ऐसी जो है बीमारियाँ है कि ये कोई डिसीज़ नहीं है, तो अभी बताइए कोई बीमारी नहीं है, ये डिफिशियंसी है कि जो हमारे शरीर में कुछ घटकों की कमतरता होने की वजह से ये तकलीफ उनको आखिरी सांस तक सहना पड़ती है। उन्हें ही नहीं तो उनके सभी फैमिली को भी इससे बहुत सारी तकलीफ होती है, बहुत सारा उनका टाइम भी वेस्ट जाता है और उनके लिए उनको पैसा भी बहुत सारा वहाँ पर खर्चा होता है। तो इसीलिए निश्चित रूप से कई राज्यों में यहाँ भी बताया अच्छा काम चल रहा है। हो सकता है कि ऐसे पेशेंट सभी राज्यों में भी हो सकते, कहाँ कम होंगे, कहाँ थोड़ी ज़्यादा तादाद में होंगे, लेकिन सभी को अच्छी सेवाएं देने के लिए सरकार हर बार प्रयासरत रहती है। हमारे भी स्वास्थ्य विभाग का यही काम है कि हमारे देश के लोगों का स्वास्थ्य अच्छा रहे, वो अच्छी तरह से अपना जीवन व्यतीत करे और उनके सभी को अपनी ज़िंदगी जो है तो अच्छी तरह जीने का हक सभी को है, तो ऐसा सभी लोगों को मिले। निश्चित रूप से मेरे स्वास्थ्य विभाग के माध्यम से जो भी आप लोगों की मांगे हैं उनके सकारात्मक विचार हम करेंगे, और ऐसे जो पीड़ित लोग हैं, जो पीड़ित परिवार है, उन सभी को न्याय देने की पूरी कोशिश करेंगे। धन्यवाद। जय हिंद, जय महाराष्ट्र।
We request our President and the management to facilitate our esteemed guest with a token of our love and gratitude. Thank you, sir, for gracing us with your presence today and addressing the gathering. We are highly obliged for the same. We look forward for your unwavering support for improvement in hemophilia management in India and for our goal, one country, one treatment.
सर, आज आपकी उपस्थिति में हम सम्मानित करने के लिए बहुत बहुत धन्यवाद। आप हम सभी को संबोधित कर सके, इसके लिए हम आपके बहुत बहुत आभारी हैं। हम भारत में हीमोफीलिया प्रबंधन के सुधार और हमारे लक्ष्य जो है एक देश एक उपचार के लिए आपके अटूट समर्थन की आशा करते हैं। तर सर, तुम्ही आमचं दुःख जाणता आणि तुम्ही आमच्यासाठी नक्कीच कार्य कराल। आत्ता तुमच्या ज्या भाषणामधून तुम्ही बोललात तर त्यातून हे सर्व आम्हाला समजतं आहे की तुम्ही आमच्यासाठी कार्यरत आहात। खूप खूप धन्यवाद सर।
Now I request our Vice President's Finance, Shri Jagdish Sharma ji, to please deliver the vote of thanks.
Thanks, Anu ma'am. Honorable Shri Pratap Rao Ganpat Rao Jadhav, Minister of State, Ministry of Health and Family Welfare, Government of India, on behalf of the Hemophilia Federation, India and the entire hemophilia community, I extend our deepest gratitude to you for gracing us with your esteemed presence today. Your support and understanding of the challenges faced by the community are truly invaluable. Your commitment to improving the health and well-being of the individuals with hemophilia inspires us to work with great dedication and challenge faced by the community. Your blessings inspires us to work with even great dedication. We are proudly grateful for your ongoing support and collaborations. Sir, I am thankful to you, sir, if you will prepare the national guidelines you will be get the blessings of all the 29, 30,000 or even more than that hemophilics of the country, sir. We are really great thankful to you. I am also thankful to the National Health Mission officials, principal government medical college, professors, NHM state nodal officers, and next to God, the doctors for their dedication efforts in making their event successful. I express my gratitude to our key persons, stakeholders, media persons, HFI staff for success of this event. I am highly thankful to the Dr. Chandrakala Madam, KEM Mumbai, Dr. Vipan Kulkarni, Assistant Director, ICMR Mumbai, Dr. Tullika Seth, Professor Hematology, AIMS, and the other dignitaries, Dr. Meera, Dr. Parul, and the other dignitaries are here. I am highly thankful to all of you for your support. Thanks a lot.
श्री प्रताप राव जाधव सर हमारे साथ यहाँ पे मौजूद है। उन्होंने अपना कीमती टाइम निकाल के हमारे बीच आए और कई सारे मुद्दों को उन्होंने टच किया। उन्होंने जो मेजरली बात कही कि हीमोफीलिया के बारे में उनको पूरी जानकारी है और हमारी अभी तक 1 से 2 मुलाकातें हुई, उसमें उनको संपूर्ण जानकारी आ चुकी है और हीमोफीलिया की पॉलिसी मेकिंग हो गई। एक देश एक उपचार यानी हमारा जो मोटो है 1 कंट्री 1 ट्रीटमेंट, इसके लिए सर आगे चल के हमें बहुत मदद, हेल्प, सपोर्ट करने वाले हैं और यही हमारी आशा है कि सर हमारे पीछे ऐसे ही गाइडेंस के रूप में हम ऐसे ही सपोर्ट उनसे हमें मिलता रहे। अभी हम नेक्स्ट सेशन की तरफ प्रोसीड करते हैं। लेट्स गो विद द नेक्स्ट सेशन। डॉक्टर राहुल सर विल बी प्रेजेंटिंग हिज सेशन ऑनवर्ड्स। लेट्स हैव अ फॉर्मल इंट्रोडक्शन फॉर डॉक्टर राहुल।
So Dr. U.R. Rahul will be representing Government of Kerala today. Dr. U.R. Rahul completed his MBBS from Government Medical College, Kozhikode, MD Pediatrics from GMC Thrissur. He served as DPM of NHM Thrissur District, Regional Director of Kerala Social Security Mission, and is currently the State Nodal Officer for Child Health and Rare Diseases, in charge of the state's prestigious programs like Hridyam, Shalabam, and Ashadara. He played an architectural role in improving the care for hemophilia and has been able to establish a good treatment throughout the state. Dr. U.R. Rahul Dr. U.R. Rahul will be speaking about Ashadhara program, the comprehensive program of the Government of Kerala. Please welcome him to the stage with a good round of applause.
Respected all, first of all, thank you for an opportunity to speak about the state-specific program, Ashadhara, the Beacon of Hope. This is the comprehensive program for management of hemoglobinopathies in our state. So it was launched in 2020, prior to which there were various issues that need to be addressed in the management of hemophilia. So prior to the launch of program, we did an analysis of what actually was the scenario in the state. We had a dedicated hemophilia treatment center at that time, which was a single center where almost 2,000 plus patients across the state had to depend on this single center. So there was also fragmentation and duplication of care leading to wastage of resources. There was a disproportionate budgetary consumption, and there was no proper data or registration mechanism where which we have a robust data of the patients, their bleeding status, and their factor consumption. So these were some of the issues that we identified, and we planned to have a focus on the outcomes and thereby improve the quality of life of the patient population. Now, we were set to a stage where we had to define our goals, how to move forward, what the issues were, and where to move ahead to. So the goals that we set out was to prevent structural deformities and disability, increase the longevity, to have a disability-free living condition, minimal school and college absenteeism, and increased workplace productivity, and overall improved patient experience from the scenario that I explained was in the state. Now coming to how we need to fix this issue. As mentioned in the previous talks, the major thing is the lack of a registry, lack of a robust data of what number of patients we have, what number of patients are not being addressed, what is their annual bleed rate, what are their major issues, and how to address. So we came up with a dedicated web-based registry for Ashadhara. Then from the single hemophilia treatment center in the state, we developed up to 19 dedicated centers, hemophilia treatment centers and daycare centers, including the facilities in medical colleges. Then we did a budget analysis wherein previously the consumption was costing around more than 100 crores, which we could cut down to less than 50 crores. And there need to be a development of a standard operating procedure and a care pathway which covers holistically the physical, mental, and social health and other aspects of the patient population. We also had dedicated HR as nurse coordinators in all our treatment centers and nodal officers at these centers who were given training on management of hemophilia. And for the holistic management, the physiotherapists across the state were given training so that the treatment doesn't end at a district level or a medical college. We have physiotherapy facilities even available at the block level at the community health centers. So to fix the issues, as I mentioned earlier, we actually processed this as how each individual centers, starting from the dedicated centers like HTCs and medical colleges, to the taluk level hospitals where on-demand treatments are made available currently. And at each level of care, from the preventive aspect, from the diagnostic aspect, from the treatment aspect, and the rehabilitation aspect, each level of care were given definitive roles and it was taken forward. So these are the roles which each centers like DDCCs, HTCs, and the medical colleges play in health promotion and health literacy of the patient population. Then the treatment option in the state, we have prophylactic treatments and on-demand treatments. All children less than 18 years are given prophylactic treatment. All the initial 50 exposures were started with plasma-derived factors with the von Willebrand factor. And after 50 exposures, we had an inhibitor screening done. Based on the inhibitor status, we either continued them on prophylaxis, or if inhibitor positive, they were left to on-demand treatment initially. Over last year and over the last week, we could start the novel therapy, the monoclonal antibody treatment for all children less than 18 years as prophylaxis. That is a recent change. Now, apart from the prophylaxis, the on-demand therapy is ongoing for more than 18 years, and the therapy is actually being given at taluk hospitals and even lower level at the block level where the facility for storage and 24-hour service is available. We are providing treatment as per the geographical mapping of the patients. Now, the management part, the prophylaxis and on-demand, as I mentioned. Now, apart from the physical health, as I mentioned, the factor replacement therapy or the medical management is just one part. The mental health counseling aspect, the social support aspects, these are all part of the comprehensive management. So this is just to summarize the entire activity of prevention, diagnosis, treatment, prophylaxis, and rehabilitation, which is given at each levels of care across the state. Now, the most important part was to monitor this. We have this centralized web-based registry where we conduct the monitoring of the factor consumption, monitoring of the annual bleed rate, monitoring of the quality of outcome, and based on that, we could do a cost analysis based on the patients who had frequent bleeding, and based on that we selected the subgroups. So to switching on to novel therapies, we actually initially selected children who are inhibitor positive. Later we selected adults who are inhibitor positive and who were frequent bleeders, where the cost of treatment with the recent medications were far more economical when compared to the previous medications with FEBA and all. And now, this is just the timeline of how this program actually progressed from the initiation of Ashadhara program in 2020 over time till the last declaration of prophylaxis for all children less than 18 years. So this was actually a progress, this was a journey. So this was a step-by-step process, and at this moment I would like to thank the entire team of treating doctors in the state who had given the constant support technically, and the patient advocacy groups who were always there day and night with us, and also the policymakers who were actually more receptive and understanding actual scenario in the state and supporting us. So this is basically the goal that has been set, that is to enhance the quality of life of persons with hemophilia by 2025. And for that, we had set up three-pronged approach to strengthen the health system, strengthening the care delivery mechanism, and enhance the accountability and governance from the administrative side. So we are making a progress in that regard, and far more to go. So this journey continues actually. So, so with that, I end the brief presentation. So it is said that to move any mountain, we need three major things, sir. One is a technically sound group, as all had mentioned about the need for a technical guidelines at national level, where we have ample number of technical experts in the country. And second thing would be the public participation, where the patient advocacy groups can have a great contribution. And third would be the administrative side, where a dedicated and goodwill of the administrative segment, the policy makers, the stakeholders have to play. So with these three pillars together, we can move any mountain, sir. With these words, I conclude my talk. Thank you.
मोती कावडे सर असतील तर त्यांनी प्लीज समोर यायचं आहे. मोती कावडे सर.
Our next speaker is Dr. Bipin Kulkarni from ICMR Mumbai, Government of India. Dr. Kulkarni will speak about ideal diagnostic requirement in state. Dr. Bipin Kulkarni is the Deputy Director at ICMR, National Institute of Immunohematology, Mumbai. He's the head of hemostasis and thrombosis research, laboratory, and molecular diagnosis. He has over 20 years of experience in hemostasis, thrombosis, platelet biology, molecular biology. Please welcome him to the stage with a huge round of applause.
So good evening. So as we know, we still have a long agenda to go, and the topic given to me is ideal diagnostic requirement in state. So first of all, I thank the HFI for having me here, and I'll try to complete in the time given to me, that is 10 minutes. Now the topic says ideal diagnostic requirement in state. So if you go to see, you can have the most basic setup and still you can make it the most ideal one if you want to do it. So I'll not go into the basics. We know what is hemophilia. We also know what is the burden of hemophilia and the other bleeding disorders. Now we know the types of hemophilia as well, so I'll not go into that again. Now this is a little older slide. So overall, we know that the burden, the rate of diagnosis of hemophilia is now, we only have about 20%, around 20 odd percent hemophilics diagnosed, and the burden is quite heavy, and we still do not have diagnosis of all the patients. So there is a long way to go. So we need more laboratories to do the diagnosis. Now we know that different bleeding disorders may have similar symptoms. So when we are talking from the point of view of having a laboratory and from the point of view of diagnosing a bleeding disorder, there are certain things that we need to keep in mind. So we know that different bleeding disorders may have similar symptoms. Now the correct diagnosis is essential to have or to ensure that the patient gets the right kind of treatment. Now this depends on following of the strict protocols and the procedures, that include basically expertise in coagulation lab testing, correct equipment, and quality assurance. These are the three most important things. With these, any small basic lab can also work wonders and do many things. Now, the diagnosis of a bleeding disorder is based on understanding the clinical features of the disease and appropriateness of the clinical diagnosis. Then comes the screening coagulation that we can do in a basic lab as well. If you have the platelet aggregometry, you can also look into the primary platelet disorders. But a good history of the patient and the family history itself will tell you whether it's a possible platelet disorder or a hemophilia-like disorder. Then the next step is going for the confirmation of the diagnosis by doing specific tests like the factor assays or the other investigations. Now the topic given is the ideal diagnostic setup. Now if you have to make your lab the ideal diagnostic, then the best thing is to follow the guidelines which are given very nicely, and to follow these guidelines, and any lab can become one of the ideal diagnostic centers. Now when a patient with an unknown or undiagnosed bleeding disorder comes to the lab, you have to think holistically. The first thing, as I said, is history, taking proper history, the patient's own bleeding history and the family history. That itself will tell you whether you are looking at and physical examination, of course. It will tell you whether you are looking at a probable platelet kind of a disorder or a hemophilia-like disorder. So you start with the screening coagulation test. Then if you get a prolongation, you do a 1:1 mixing. Then if there is normalization or no normalization, depending on that, you proceed along with the factor assays. You also do the inhibitor screenings. And at the end of it, you may end up getting a coagulation factor deficiency with or without inhibitor. Parallelly, if you have access to the platelet aggregometry and if you suspect a platelet kind of disorder, you can look into the platelet aggregation part as well, mostly the resorcitine sulfate-induced platelet agglutination, which will tell you about the von Willebrand disease. But having said that, now we have the point-of-care test for detecting severe to moderate hemophilia A and von Willebrand disease. So you can as well use those along with doing the screening coagulation and looking into the band for the von Willebrands, if it is there or not there, to distinguish at that point whether you are looking at hemophilia A or you are looking at von Willebrand's disease. So why is it essential to have a correct laboratory diagnosis of hemophilia A? Now, oftentimes we get referrals, because we are also a referral lab for doing the prenatal and carrier and prenatal diagnosis of hemophilia. Oftentimes we get a diagnosis of the proband as hemophilia A, and only the factor VIII assay is done, and there is no von Willebrand antigen testing is not done. So there, directly going for a molecular testing could be risky, because you may or may not be looking at hemophilia. It could be von Willebrand disease as well. So either you need to have a proper pedigree, family history, and yet if there is no family history, that doesn't still rule out that it could be still von Willebrand disease. So why it is important to have a correct laboratory diagnosis is if subsequently when this family goes for a molecular carrier detection or a prenatal diagnosis, then it's essential to know what was the diagnosis of the proband in the family, whether it was hemophilia A or von Willebrand disease. Your entire molecular workup will depend on the accuracy of that diagnosis. Now, while establishing a coagulation laboratory, one may face with several challenges, like right from the selection of the equipment, what equipment to use, selection of methods and the validation of the methods, regulatory compliances, quality control and proficiency testing, staff training and competency assessment, sample management and handling, data management and reporting, and of course, troubleshooting and maintenance of the equipment, as well as maintaining your reagents in the right condition. So once you are aware of all these challenges, you can find ways to tackle with them, and you can still manage to make your lab the most ideal one. Now, to start with coagulation testing, you do not need a very hi-fi setup. You can start with a very basic coagulation lab setup. Now, this is what we had made some time ago, like how much expense actually you have to spend to start a basic coagulation laboratory. It's not much if you look into, but eventually you can step up one by one. Like what you need to have is stick to the basics, stick to the guidelines, and do whatever you're doing, you do it right. So once you start doing things right, you can gradually scale up to do many things afterwards. But all you need is to begin at some point and begin with the right kind of attitude and doing things right. So as I said, you do not need a very hi-fi setup. Even the most basic setup is good enough to do a lot of things. Like it is important to evaluate whatever equipment you are using. It may be a simple water bath, but it has to be accurate. It has to give proper temperature. It has to, so whatever equipment you are using, it is important to evaluate the performance, reliability, and compatibility of the equipment with the laboratory needs and the sample volumes. Now, if you are a hospital lab doing PTs and APDTs, then obviously you will need a bigger automated instrument where you can run batches of PTs and APDTs. But if you have to, or if your intention is to identify a bleeding disorder, if your intention is to identify hemophilia to do inhibitor testing in those samples, you really don't need those kind of big instruments. You can do it even with the smallest of semi-automated machines, or even on a water bath if you don't even have that. All you need is a good technical skills. Now, if you're using automation or semi-automated machines, it's better to use open systems where you can use any reagents that that you want to use over a period of time, or to do any specific investigations. Consider feasibility of smooth availability of consumables. Like many times we see that you get big equipments, but there are no consumables and the equipment is just lying idle. So make sure that you have the basic setup, but have the reagents and consumables coming to you regularly. It's important to select the right kind of methods and to validate those methods. So to ensure the continuity of supply of the chosen reagent batches with good shelf life, that is important. Establish your own laboratory reference ranges for all methods used. So this is very important, like to have your own laboratory reference ranges for all the assays that you're doing. Like for example, if you are collecting the normal pool plasma in-house, or if you are collecting the deficient plasma from the hemophilic donor, you have to have, every time you change the lot, you have to have your own reference ranges for those batches that you're doing. Choose the right kind of reagent fit for the purpose. I'll come to this in the subsequent slide. Selecting the appropriate methods and validating them for accuracy, precision, and reproducibility is essential to ensure reliable results. This is very, very important. Now, we know that this is the example of factor VIII assay. So we have the one-stage assay versus the chromogenic. Now we know that the chromogenic assay is the gold standard, but you don't always have to do the chromogenic assay. You may not have the facility, you may not have the expertise or facility to do it. Doesn't matter, you can do it even with a one-stage assay, provided you know what are the variables that you can control and you should control. If you know that very well, you can even do a good factor assay even by doing the one-stage factor assay. Like for example, if you are using the APDT reagent, there are various types of APDT reagents containing various different types of activators, phospholipid contents. Then you have the source of your deficient plasma, whether it is commercial or sourced from a patient. So these kind of things, if you know very well and if you control them, you can do even the one-stage assay very well. Now, there are variables that can affect APDT, as I said. So the factor assay performance can be affected by the type of contact factor, contact activator, like varies with the APDT reagent. So there is ellagic acid, there is kaolin, there is silica, there are many types of contact activators. So what works best, the sensitivities could be different. The factor deficient plasma, as I said, if you are sourcing it from the patient or you are sourcing it from commercial source, that will affect your assay. Instrument on which the assay is being performed. So choose an instrument that will give you consistent readings and it is well calibrated. Now, the APDT reagent, I spoke in the previous slide. Now, there are different types of APDT reagents having variable sensitivities to coagulation factors. So some APDT reagents, they are not very sensitive to mild deficiencies. So where is this important? I'll come again in the subsequent slide. There are reagents with variable sensitivities to lupus anticoagulants. Like for example, if your APDT reagent contains low concentration of phospholipids, then it can give you falsely prolonged APDT because of the transient lupus anticoagulant that may be present in the plasma. So if your goal is to identify a bleeding disorder, then you should select the APDT reagent that has high concentration of the phospholipid. There could be variable sensitivities to heparin and variable sensitivities to the extended half-life factors. Now, there are beautiful, in the guidelines, World Federation of Hemophilia guidelines, there is a beautiful section, and there are other publications as well which tell you which of the reagents or which of the APDT reagents are suitable if you are using specific extended half-life factors. So one has to be aware of that. So I said about variable sensitivities to the mild coagulation factors. Now this table shows you the different factor levels at which you get a normal or near normal APDT. So just imagine that, if somebody has a factor 8, if somebody has a normal to near normal APDT with factor 8 of 35%, and if he goes for surgery, then he'll definitely have bleeding. So one has to be very cautious about picking up the right kind of reagent that is sensitive to even the milder deficiencies. Now, I spoke about the extended half-life factors. So there are various extended half-life factors available. And this table shows, this picture shows the different types of APDT reagents that are available containing different activators. And on the x-axis, there are the different products, extended half-life products. And this table shows which reagent fits for what kind of extended half-life product is being used. The next is emicizumab. Now one has to keep in mind that emicizumab, which is a humanized bispecific monoclonal antibody, if once a patient receives it, we cannot use the conventional assays, laboratory assays, to monitor this patient, or the APDT or the inhibitor screening or the factor 8 assay. It cannot be done using the conventional method. Even if the chromogenic assay is to be used, the chromogenic assay has to be of the bovine. The reagents have to be bovine reagents, not the human reagents, because that will interfere in the assay. So one has to be aware of these things while approaching these kind of samples or while dealing with these kind of samples. So the most important thing is communication between the lab and the clinics. The lab should know what the clinics are doing, what products the patient is receiving, and accordingly what investigations, how the investigation is to be modified. Now, here you do not again need a very big setup. You can do it on a small machine itself. All you need to know is to be very clear and aware of what is being done in the clinics, and just to have a set of reagents that you can use and you can still give accurate results. Now these are the different, these are the guidelines which talk about the assays recommended in the World Federation of Hemophilia. If the person is on emicizumab, so you have to use the bovine reagents for the chromogenic assay, or you have to use the EHL calibrated plasma for doing a one-stage assay. Now, if you can do a PT, prothrombin time in the lab, you can as well do a APTT. If you can do a PT and APTT, you can as well do a factor assay. It's an extension of that. If you can do PT, APTT, and factor assay, you can as well do inhibitor screening. You can as well do the Bethesda quantification. It's just an extension of one thing leading to other. So it doesn't need any hi-fi equipment, or, you know, all you need to have is a good technical skill and a good skill to interpret what you are getting. So here I just want to say that even if the assay looks very complicated, it can be very easily done, even in a very basic setup. The most important thing here is the quality control and proficiency testing. So to have internal and external QC, no matter how small or big your lab is, it's very important to have internal and external QC. So internal QC is to establish whether the techniques are reproducible over a period of time. And the external QC will help to identify the degree of agreement between your results as well as and the other labs which are doing these investigations. Now, to have this, it is very essential to have appropriate reagents and techniques and a trained staff. So these are the most important things to have. So these are just our QC that we are doing. We are enrolled with the World Federation of Hemophilia QC program for the coagulation assays, and we are enrolled with the CMC Vellore molecular genetic ICAS program for the hemophilia carrier and prenatal diagnosis that we are doing. Important thing again here is the staff training and competency assessment. So even the World Federation of Hemophilia guidelines say that they recommend that the testing for diagnosis and monitoring of hemophilia must be carried out by staff with knowledge and experience in coagulation laboratory testing. So this is a most important thing, and these are the pictures of some of the trainings that we have done as a part of like we being a tertiary referral center, and giving trainings is one of our verticals, and we are also one of the 2 IHTCs in the country. So I'll not take long coming to the end of it. So you can basically do the coagulation right from, you can choose to have a water bath, or you can have a semi-automated machine, or if you can afford, you can have a fully automated machine. That actually doesn't matter. But as if you can scale up, you can really scale up to whatever you want to do. So you can, this is a picture of TEG and ROTEM. Obviously, it is not required in the routine setup at all. But if at all you want to scale up to do some research work, you can do it later on. So this is the thrombin generation potential, the ETP. And so while doing all this, one has to remember the most important thing is, before starting even with the lab investigations, to understand what are the pre-analytical errors. Because about 70% of the errors are pre-analytical, before even the testing starts. So it is very important to be aware of pre-analytical errors that can happen even before the sample comes to the lab. So if you control those, then, and along with your laboratory skills, you can have very good results, and you can fit in all the quality control criteria. Coming to the data management and reporting, obviously a coagulation lab testing generates significant amount of data that needs to be accurately recorded, interpreted, and reported. So if you're doing the investigations and you're not recording it properly, not interpreting it properly, then everything done is gone. So now ideally, if you are based in a hospital, then the coagulation lab should ideally be giving 24-hour service, especially for factor VIII and inhibitors, because that matters a lot. Now that is one limitation that my center has, because my center is a central government ICMR institute, and we work Monday to Friday. So Dr. Chandrakala has many times problems when we are not working on Saturday, Sundays. So if if you are a hospital lab and if you can provide that kind of service round the clock, that's the best thing you can do, particularly factor VIII and inhibitors testing, if you can provide, if not all the others. Now, as I said, it is very essential to have good communication between the hemostasis laboratory and the clinics. So that, because that communication is extremely essential to not have any confusions regarding what product is given, what investigation is to be done, what reagents are to be used. Implementing an efficient laboratory information system, that is the LIS or laboratory management system, to handle the data entry, result verification and reporting is essential for smooth functioning. Like regulatory compliances, wherever you require, if you require the CLIA regulatory compliances, you have to be compliant with that, and ensuring compliance with the standards and maintaining necessary documentation can be challenging, but it is essential for providing quality patient care. And lastly, but very important, troubleshooting and maintenance. If you are having an equipment or any, be it a small or a big equipment, it could be just a water bath, but it's very essential to maintain those equipments. So every now and then a lab can encounter instrument malfunctions, failures, reagents issues, or other technical problems. So to minimize this downtime, it is important to have a system for troubleshooting and regular maintenance. As far as possible, get into a AMC program, or at least have your technical person who can maintain it in-house. Good relationship with the equipment manufacturers or service providers. This is our even personal experience, that your equipment may not be in AMC, or the AMC might have expired. But if you have good personal relation, and if your machine is having a downtime, you can have a personal call, and the fellow will come and do it for you. So that matters a lot, irrespective of whether you are having a, if your AMC has just expired or whatever the situation may be. Now, addressing these challenges required careful planning, collaboration with experts, and ongoing monitoring and evaluation to ensure the quality and reliability of coagulation testing. So, at the end of the day, how much is enough? So, it is essential to have an understanding of the necessity of laboratory investigations, understanding what investigations to perform, understanding the pre-analytical variables, selecting the right reagents for testing, using the right methods for testing, developing technical expertise, developing interpretation skills, very crucial, enrolling in laboratory QC program, efficient transfer of technical skills, because this is a common problem with state government or any government labs, that a trained technical person is transferred, and then everything, the skills are lost. So there should be an efficient mechanism to efficiently transfer the technical skills before you relieve your existing technician. And as I said, having simple testing methods like POCs. Wherever you have the POCs available, please go ahead and make use of those, and it will minimize a lot of your labor. So to conclude, for accurate laboratory testing for diagnosis and monitoring of hemophilia, you require close collaboration between the lab and clinic, regular availability of reagents, follow the guidelines on laboratory diagnosis and monitoring, and you have trained lab staff with expertise in selecting and performing correct methods. So with that, thank you very much. This is our HCCC team. Dr. Chandrakala is here today, and these are all the other members in our team. And this is my small lab team. Thank you very much.
Hemophilia, sir, and he got some accident. So that may be a breakthrough bleeding, so he is going for a surgery. At that point of time, if we will go for the inhibitor status, will that affect his factor level and inhibitor status, sir?
So if as I said, if the patient has taken emicizumab, the regular inhibitor screenings or the factor levels or the PTs, the APTT, it will not tell you anything about, it will not give you the right results unless you are using the right kind of reagents when the patient is on emicizumab, either the bovine containing the bovine reagents, the chromogenic assays, or the emicizumab standards for the one-stage assay. So you cannot use the regular inhibitor screening and testing if the patient is on emicizumab.
Okay, sir. Thank you, sir.
Thank you.
Thank you, Dr. Bipin Kulkarni, sir. I request our EC member, Shri Dinesh Vadadia, sir, to please felicitate Dr. Kulkarni with a token of our love. A big round of applause, please. I request Dr. Cecil Ross, sir, to please felicitate Dr. U.R. Rahul. A huge round of applause, please. Next, we have our panel discussion, Establishing Services for Hemophilia Care. The moderator is Mr. Santosh Manivannan, the Youth Group Chairperson of Hemophilia Federation India. He is a person with severe hemophilia B. He is an entrepreneur, and he has been volunteering for the cause of hemophilia since age 15. Please welcome Mr. Santosh Manivannan to the stage.
Hello. Hello. Yeah. Thank you very much for the introduction, Anu. So, without further ado, I would like to call upon our panelists for the evening. I would like to call upon Dr. Ritu Sarkar. She is the in charge of hemoglobinopathies at the National Health Mission for the Government of Assam. Next up, we have Dr. Kavindra Lal. He's the State Program Officer, National Health Mission, Government of Himachal Pradesh. Next, Dr. Sonia Mohan, Pathologist, National Health Mission, Government of Andhra Pradesh. Next up, Dr. Nidhi Galre, Deputy Director, National Health Mission, Government of Chhattisgarh. Next, Dr. Babi Gulati, State Nodal Officer, National Health Mission, Government of Punjab. Next, Dr. Parul Bhatt, Professor and Head of Department Medicine, GMERS Medical College and Sola Civil Hospital, Ahmedabad. And then we have Dr. Bilal Ahmed Sheikh, Head of the Department, Pathology and Blood Center and Immunohematology, Government Medical College and Associated Hospitals, Srinagar. First of all, I would like to thank all the panelists for spending the time with us, and I would like to welcome them on the dais. All right, just before we get started, I think all of the mics are off, so if you would please make sure your mics are on, and then we can probably get started. Sir. So before we start off, I would like to set a baseline so we all understand where the bureaucrats on the dais come from and what their state is currently capable of. So the first question would be, what is the current scenario of hemophilia treatment and access in your state? Let's start with Dr. Kavindra Lal.
See, Himachal, I am from Himachal. Himachal is a small state and we have a very difficult topography. So initially last year we had this hemophilia, we have about to 25 patients of hemophilia. Mostly they are children, and they are, we have been treating them at different levels. So initially it was only this plain factor 8 and 9 were available in the state. But now after this when the emicizumab has been added, and we have already, now we have factor 7, factor 8, factor 9, factor 10. And apart from that, even the inhibitor, that factor 8 inhibitor bypass activity, that also we have included. Now we in the Himachal, because topography is difficult, we are planning to have these factors available at district levels. We have 12 districts. Out of 12 districts, the 3 districts are tribal areas are there. And in 6 of the districts, we have 6 medical colleges. 7th is, one is aimed in Bilaspur, and there is one medical college in another district. So out of 12 districts, we are covering 9 districts. And in tribal areas, we don't have any patient of hemophilia. We want to have these, we have registered almost all the patients, and we are calculating, we have to calculate the dose. So that, to avoid the duplication, because there is a duplication, because if you get factors not in one place, the people, they go to other districts and they make SIPs there, so that they can get the, there is a duplication of patients. So for that, based on Aadhaar card, we will be making their list, and which will be available with the central agency, that is in the headquarters. We have one hematologist in medical college at Shimla. So that is the strategy. I think so.
Yes.
It will help to bring the patients so they are nearer to their place of residence. Thank you.
Thank you, sir. Next up, Dr. Parul.
Good evening, everyone. This is a tiring time now, but shortly I can say in Gujarat state, we have total diagnosed case. Those who are enrolled all over the state, 29 states comes under, this comes under our Gujarat Sola hospital. Districts are enrolled. Out of that, 250 to 300 patients are been enrolled at GMR Sola under medicine department. And right now, 200 patients are ongoing on treatment. They are moderate to severe hemophilia been diagnosed. Rest other are on demand. So we have made a policy at our institute that those who are having mild on demand, they will be treated as a on demand as and when they have bleed. But if the frequency of bleeds are more, then we will think them as a moderate. But the moderate to severe cases right now on treatment are 200 patients in under medicine department. Out of that, hemophilia A and B both have been diagnosed. The important part I would like to share is that we have diagnosed all the cases for their inhibitors. We are routinely we are advising them every yearly once inhibitor level. Out of that, we found out a total 18 patients right now, but the 10 patient has already been successfully cleared their, they put on a ITI, that is immune tolerance induction, and they have successfully completed their ITI, and they have been put on a previously short-acting factor 8 prophylaxis, 3 times, the alternate day 3 times a week, and then they are right now on a EHL prophylaxis. And another important aspect I would like to share is that we have right now 24 patients, those who are already been screened for the inhibitors and they are negative. They are on the extended half-life clotting factor 8 prophylaxis once in a week, 50 IU per kg. And we have 10 patients on emicizumab as well. So, and 8 patients on the Refixia. They all are mostly all the patients, those who are moderate to severe, we have a policy at our institute to put them on a regular replacement therapy, that is in a prophylaxis. And second policy we made is a inhibitor testing as and when we feel the patient is having a requirement of the more factors, or either they may have a bleeding tendency. And at the same time, we have introduced in our institute the physiotherapy regularly. And most of the patients, those who are on prophylaxis, they are doing physiotherapy 7 days a week regularly. Their HJHS and the FISH score, both the scores are improved drastically, and they just are living their normal life as. And we one important thing that when we put the patient on a prophylaxis, we go through the factor assay activity as well. Within a 7 days, what is happening? So they maintain the factor assay in the body, not less than 1%. So all are doing just like a normal person. So that is what we are doing at our institute.
Thank you, ma'am. I will move on to, Dr. Bobby, please. Can you share?
I'm from Punjab. We have 24 districts and we have 713 patients registered. तो इस बार हमने एक आई केयर सॉफ्टवेयर रजिस्ट्री शुरू की है और क्योंकि पहले बहुत सारी डुप्लीकेशन होती थी और हम कभी कैलकुलेट ही नहीं कर पाते थे कि स्टैटिक वैल्यू आती थी 500 पेशेंट्स हैं और वो पता नहीं कितने सालों से 500 ही चली आ रही थी, तो अब उसके हिसाब से ही हमें प्रोक्योरमेंट करनी पड़ती थी। तो अभी हमने एक आई केयर रजिस्ट्री की है जिस पे हमने सारे पेशेंट्स को डालना कंपलसरी किया है। बिना उस पर डाले जब तक पेशेंट रजिस्टर नहीं होगा तो वी जनरली डोंट गिव पेशेंट, ओनली वंस द पेशेंट रजिस्टर्ड देन वी गिव द पेशेंट। तो सबसे पहले हमारी जो आई केयर रजिस्ट्री में हमें थोड़ा आइडिया लगना शुरू हुआ है कि कितने पेशेंट्स हैं, उनकी प्रॉपर हिस्ट्री अभी भी मतलब पूरी डिटेल में अभी धीरे धीरे आनी शुरू हुई है पर अभी पूरी आई नहीं है। सेकेंड थिंग, स्टार्टिंग विद अवेयरनेस, वी ऑल नो कि चाहे कुछ भी कोई भी कहता रहे, मेरे हिसाब से लोगों में अवेयरनेस की तो बात हम कर ही नहीं सकते। हमारे मेडिकल जो प्रोफेशनल हैं उनमें भी हमारी, एक्सेप्ट डॉक्टर्स, इफ़ यू गो टू एनी हॉस्पिटल एंड यू टॉक टू स्टाफ नर्सेज, यू टॉक टू लेबॉरेटरी टेक्नीशियंस, यू टॉक टू एनी फार्मासिस्ट, दे मे नॉट हैव हर्ड द वर्ड ऑफ हेमोफिलिया, उनको आइडिया ही नहीं होगा। ठीक है, तो देन अवेयरनेस के बाद आ जाओ डायग्नोस्टिक्स में। डायग्नोस्टिक्स में सर ने इतना अच्छा बताया है कि डिस्पाइट वो सेमी कोएगुलोमीटर्स अवेलेबल कराने पे सारे डिस्ट्रिक्ट्स पे, पहले तो सेमी कोएगुलोमीटर जब अवेलेबल कराए, उनकी किट्स अवेलेबल कराई, तो जिसको किसी को मतलब उनको ऑपरेट करना ही नहीं आया, तो जब तक उनकी दोबारा ट्रेनिंग कराई तब तक किट्स एक्सपायर हो गई, जब तक नई किट्स दिलाई तब तक सेमी कोएगुलोमीटर ख़राब हो गए, फिर दोबारा से जब तक दोबारा किट्स दिलाई तब तक वो जो पहले ट्रेन कराए थे बंदे वो चेंज हो गए। सो बहुत बड़ी प्रॉब्लम, चाहे कोई भी कहता रहे, वी हैव द सेमी कोएगुलोमीटर्स इन ऑल डिस्ट्रिक्ट्स, वी हैव द किट्स इन ऑल डिस्ट्रिक्ट्स, और जैसे सर ने अभी क्लियरली एक्सप्लेन किया कि सबसे बड़ा इंपॉर्टेंट है एक्सपर्टाइज होना, तो वी डेफिनेटली लैक एक्सपर्टाइज इवन इन पंजाब। देन कमिंग टू ट्रीटमेंट पार्ट में पिछले साल तक हमारे पास बड़ा लिमिटेड बजट होता था, 14 करोड़ के करीब बजट आता था, जिसमें फैक्टर 8, फैक्टर 9 और सिर्फ 2.5 करोड़ बजट जिसमें हमें फीबा, एपीसीसी और एमिसिजुमैब के लिए होता था। तो हमारे ऐसा सिस्टम है, मोस्टली रीअप्रोप्रिएट नहीं करते, जितना बजट जिसके लिए अलॉटेड है उतना ही मिलता है, ज़्यादा से ज़्यादा रीअप्रोप्रिएट 10% होता है। तो उससे बजट की बहुत प्रॉब्लम्स आती थी और सप्लाई हम जितनी मर्जी कोशिश करते थे रेगुलर सप्लाई नहीं मेंटेन कर सकते थे। तो इस बार ईडीएल में डालने की वजह से अब जो सप्लाई है काफ़ी रेगुलर हो गई है, और अभी भी इंजेक्शन एमिसिजुमैब या नॉन फैक्टर थेरेपी है वो ईडीएल पे नहीं आई है। आई थिंक उड़ीसा है, हिमाचल है, हरियाणा, तीन स्टेट्स ने अभी ऐड किया है उसमें अपना ईडीएल में। बाकी ना तो ये आईपीएचएस की लिस्ट में है ना नेशनल ईडीएल लिस्ट में है। तो मेरी रिक्वेस्ट होगी कि हूसोएवर आर ऑर्गेनाइजिंग और जो भी नेशनल एनएचएल के लेवल पे जिनका भी कनेक्शन है, तो दे शुड इंश्योर कि जब तक एमिसिजुमैब या नॉन फैक्टर थेरेपी नहीं आएगी उस पर, तो उतनी देर तक ये प्रॉब्लम जो है बजट की तो प्रॉब्लम ख़त्म होगी नहीं। तो अल्टीमेटली एज मैम डॉक्टर तुलिका हैड सेड कि सबसे पहले वी हैव टू कम टुवर्ड्स EHL और प्रोफाइलैक्टिक थेरेपी, तो वो इंजेक्शन एमिसिजुमैब या उसको डालना ही पड़ेगा। हमारी स्टेट में वो ईडीएल लिस्ट में नहीं है फॉर्चुनेटली। इस बारी पहले एनएचएम ने कहा कि हम पैसे नहीं देंगे फैक्टर्स के लिए, पर उतनी देर में हमने बहुत मेहनत करके स्टेट शेयर डलवा लिया। स्टेट ने पैसे दे दिए और उतनी देर में NHM से भी आ गया. सो होपफुली वी विल नॉट हैव द प्रॉब्लम ऑफ बजट और प्रोक्योरमेंट ऑफ फैक्टर्स, और हम रेगुलर सप्लाई जो है फैक्टर्स की दे पाएंगे. उसके बाद कमिंग टू, जैसे हम कहते हैं ऑर्थोपेडिशियंस की इन्वॉल्वमेंट इसमें, या किसी भी सेंटर पर सर्जरी की इन्वॉल्वमेंट, मेरे को नहीं लगता कि चाहे कोई कितना भी कहता है. पंजाब में तो एटलीस्ट हमारे 24 सेंटर्स हैं, डिस्ट्रिक्ट लेवल पे सर्जरी नहीं हो पा रही, और बहुत मुश्किल से एक आधा शायद मेडिकल कॉलेज होगा जहाँ फरीदकोट है जहाँ थोड़ी बहुत सर्जरी, मैं शॉर्ट कमिंग्स बता रहा हूँ अपने प्रोग्राम की, मैं वो नहीं बता रहा. तो जहाँ पे सर्जरी एक्चुअली होती होगी, जैसे डॉक्टर साहब ने पहले कहा डेंटल एक्सट्रैक्शंस के लिए, ऑर्थोपेडिक सर्जरीज़ के लिए, तो हमें अभी भी पेशेंट PGI में भेजने पड़ते हैं, PGI में सर्जरीज़ होती हैं. तो नेक्स्ट ये हो गया. उसके बाद हम फिजियोथेरेपी की बात करते हैं. फिजियोथेरेपी यूनिट्स तो हैं, पर ट्रेंड स्पेसिफिकली फॉर हीमोफिलिक्स ऐसे वो नहीं है. इवन प्रॉब्लम्स जैसे ये ट्रेनिंग, मतलब हमें स्पेसिफिकली ट्रेंड चाहिए होंगे फिजियोथेरेपिस्ट, जो कि इसको अभी वी विल बी वर्किंग ऑन दैट. देन कमिंग टू द नेक्स्ट, डिसेबिलिटी सर्टिफिकेट्स के बारे में. डिसेबिलिटी सर्टिफिकेट्स हम बार बार कहते रहते हैं, उनको थोड़ा स्पीडिशियसली बिना पेशेंट्स की इनकन्वीनियंस के लगातार बनते रहें, पर उसमें भी पेशेंट्स को थोड़ी प्रॉब्लम आती है. ट्रीटमेंट पेशेंट जब लेने जाता है तो उसको प्रॉब्लम आती है कि 24/7 वही, अगर नोडल ऑफिसर है वो सुबह 8 घंटे मिलेगा, बाकी के टाइम नोडल ऑफिसर नहीं मिलेगा. तो वही स्टाफ जो है, कई बार स्टाफ ऐसी होती है बच्चों को इंट्रावीनस देने में उनको प्रॉब्लम होती है, तो मल्टीपल प्रिक्स की प्रॉब्लम बहुत जो बच्चे कंप्लेन करते हैं. सो कैपेसिटी बिल्डिंग विल बी अनदर जिस पे हमें अभी बहुत सारा वर्क करना है. सो डिसेबिलिटी, ये जो सारी चीज़ें हैं, मतलब वी हैव एक प्लेटफॉर्म बना लिया है, पर इन सबको अब जैसे एक अच्छा सेंटर जो एक एक को करके फोकस करना बहुत ज़रूरी है. एंड आई होप कि नेक्स्ट टाइम व्हेन वी मीट वी विल बी एबल टू हैव बेटर centers in Punjab also. Thank you.
Thank you, Doctor. Next, I would like to request Dr. Sonia to share the current scenario of hemophilia treatment and access in your state.
Good evening, everyone. I am Dr. Sonia. I represent Andhra Pradesh Blood Cell under NHM. It's a privilege to share the stage with all the panelists, and I thank HFI for giving me this opportunity. So coming to Andhra Pradesh, we earlier had 13 districts. It has now become 26. So earlier there were only standard life therapy, standard factor therapy that was there, SHL, initially. And those were initially plasma derived. Then we have stepped on to recombinant versions of standard factors. Now we are also using EHLs, that is extended half-life factors, in most of the teaching hospitals, and we are about to introduce it even to the district level hospitals. And we are also running a pilot project with a monoclonal antibody that we've already discussed earlier, emicizumab, in 3 of the districts and the teaching hospitals, which is still under the research. And coming to the statistics, altogether the patients in the state with bleeding disorders are 1,200 cases. Of that, hemophilia A cases are around 770 to 800 cases, and followed by hemophilia B and then von Willebrand factor disorder cases. And the other percentage will include the other bleeding disorders. So it is a collaborative effort that is put by the societies across the state and us to maintain the data and to reach the patients. Though we don't have a state level registry or something, they usually register at the society level and they approach us, and whenever there is an emergency or a life-threatening bleed, the coordinator or the representative from the society immediately coordinates with the nearest teaching hospital or the district level hospital, and we try to manage it at the earliest possible with the bypass agent available or the best factor therapy that is available for the patient as the need of the hour. And we face problems regarding That is, as we all know, we document things, but accountability is an issue. Under NHM, factors are procured, given to the teaching level hospitals or the district hospitals, but we don't have a track what happens to these factors. Are they being utilized at the right level, or are there any factors being left or expired? That tracking is a bit lacking as far as we have intruded and tried to analyze. As Dr. Rahul had mentioned, they've analyzed it and they have reduced their cost with a better cost-effective analysis. So we are also trying to do that. Especially, I would recommend, like, if there is a national registry like it was proposed earlier, with the portal having the track of the factors that we give, or the therapy, whatever is given, if it's a factor therapy or a non-factor therapy, it would be like a total monitoring of whatever service we give. The patient will be registered and the patient will be taking the treatment, and what happens after that will also, the follow-up can also be monitored. Also, sometimes what happens is NHM, though it is said that health is a state subject, some patients go across the state. That's when issues come where the other state probably can't provide factors. Though they don't deny, they provided the basic thing. But the patient is unable to travel, and consistently factors from another state will be a burden on them. So we still try to coordinate the patient and send them to the nearest society or the teaching government general hospital so that they get services in the right time. So we were on the factor level therapy. Now we were going into prophylaxis. I feel there is a massive improvement that is going on. Though there are challenges, pros and cons of everything in healthcare. So I think we are on the progress. Thank you.
Thank you, ma'am. Next up, I would like to ask Dr. Nidhi.
Good evening, all. Good evening, all. I'm representing state of Chhattisgarh. In Chhattisgarh, we are having 33 districts and 10 medical colleges. Along with that, we are also having a hemoglobinopathy center in the name of Center of Excellence for Sickle Cell. So we are doing very well with the sickle cell. In that institute, we are also dealing with hemoglobinopathies, including thalassemia as well as hemophilia. In our state, this facility of providing factor is being practiced in all the district hospitals, medical colleges, as well as in the sub-center levels also. That is basically done in coordination with NGOs as well as the government sector. Around 350 candidates or registered number of patients are there with us, whom we are providing factors at different levels. The thing which we are practicing is providing factors on demand, but that too we provide for 3-month basis, and before the factor is consumed by the patient, we supply it in the chain system so that the patient is not find deficient of the factor once he or she requires. In that case, we can say that prophylaxis also is maintained, or the supplementation as the patient's requirement is also being done. Pain crisis management is being done at district level, at medical college level, and the coordination with the NGOs is also being done. With the help of those NGOs, we are supplying the factors to each and every patient which is registered in the government sector as well as in the private sectors. What we face that the patients in the private sectors, they get diagnosed over there, but they turn on to the government sector for availability of the factor. And that is being supplied by the district level and district authorities. As Punjab said that they have developed a system to procure this availability of the factor from state level, that we are also doing it from district level at the level of Jeevandeep Samiti, that is monitored by the district level, and head is the collector. Through that, we are also procuring that factor to the patients who are turning on to the district level. One more thing which we are practicing at different levels, at different districts, the factor is available. But once we see that the patient, maybe some district is not having that factor at that time which the patient is required. So it can be traced from the app, and through NGOs or through our monitoring system, through our health providers, that is the Metanin or ASHA or medical officers, through that app they contact us, and we make the availability of the factor to the patient who is requiring it from other district. Maybe the patient is from Jajgir, I'm just taking the name of some district, or some Baloda Bazaar district. Patient is from Baloda Bazaar, factor availability is in Jajgir, so availability is made through that app and through the coordination of our health providers and our NGOs, so that the crisis is overcome and the factor is being supplied to the patient. In that case, the coordination which we have previously discussed is also being done. That is it. And we are also looking forward for the extra procurement of the new techniques and new devices which we have all mentioned here. Thank you.
Thank you, Doctor. Next up, I would like to ask Dr. Ritu.
Good evening, everyone. I represent NHM Assam, myself Dr. Ritu. So currently in our state, we have 5 hemophilia treatment centers, out of which the Guwahati and the Dibrugarh ones are the oldest, and they have the treatment and both diagnostic facilities. And we have 3 newly opened treatment centers, that is in Borpeta, Jorhat and Silchar. So they are also growing drastically and they are also catching up. So in Guwahati chapter only, we have around 293 patients and around 138 patients from Tinsukia chapter, so which sums up around 431 patients. And if we do all total, then it comes to around 800. So other than that, we are providing them with the factor 7, 8, 9, recombinant 8 and 9, plasma-derived factors, and imacizumab. So we have around 90 patients receiving imacizumab. So other than that, one of the greatest achievement which I think is we are giving home treatment to our patients from 2012, and from 2017 we have also started giving prophylaxis, home prophylaxis. So it has really helped in early prevention of bleeds and all for the patients, and it really helped during the COVID times also. So other than that, a few days back we conducted a state level program for the awareness and diagnosis of the hemophilia, in which we invited a doctor and technicians from all the 7 northeastern states, and they were giving training regarding the diagnosis and treatment, and also the newer treatments which have arrived. And the major issues which we face in our state is that there is very less awareness regarding this disease. So we are planning to conduct a CME in our state, in which we will invite all the doctors and medical professionals from all the districts to basically make them aware about this disease, and also the patients with hemophilia and the NGOs who are also currently working with us and helping us. So to spread awareness about this disease, because most of the people in our state are below poverty line, and they have very less literacy and very less knowledge about this disease. So it is one of the greatest challenges for us to spread awareness, and so there would be early diagnosis and treatment about this disease. Thank you.
Thank you, Doctor. Next up, I would like to ask Dr. Bilal about the current scenario of hemophilia treatment.
Thank you. I will thank HFI for inviting me and to share my current scenarios. I'm representing the Kashmir part of J&K. So I will just briefly mention the brief journey of the hemophilia care in our state. We started after a appeal in the Honorable High Court in 2011, and the government was, forced to give the, budget for the hemophilia. In 2011, they assigned 2 crore rupees. And that made the, factors available in the center. And it was the availability of the factor in the center which, recruited the patients, because the factor was costly thing, and we were able to, just make the registry from that. And 2013 to 2019, we were only, just because of the limited budget they were giving us, and we were only giving on-demand therapy to the people with persons with hemophilia. So in 2019, there happened the lockdown of post 370, because it has been said that this is the necessity is the mother of invention. So everything was closed, everything, and there was the thing that we had the factors also, and we started the prophylaxis and the home therapy. So our ambulances were carrying the drugs to the doorsteps of the patients, and that gave us some, the innovation of home therapy, that yes, home therapy is very important. And we started prophylaxis with the standard half-lives, because a non-factor was not available till 2021. And all our severe hemophilics were on the prophylaxis. We are thankful to the government, and because they were providing us all budget, we had all factors available in that standard half-life product. And 2021 we had with the non-factor. We started with non-factor, and in between there was in 2017 we started a coagulation lab. I mean, what is the importance of lab is very important, because in 2000 you can just imagine. 2017, we had only 330 patients registered with us, and now at this present, we have 427. And at least every year, we are adding 10-15 patients of hemophilia to the registry because of the diagnosis. So, and we are lucky in a sense that we have all sort of budget, and we have all sort of products available except plasma derived. We don't have plasma derived factors, although we have the RC for that. We have all sort of drugs which are available. I mean, we have a standard half-life, third generation. We have EHL. We have non-factor. So our 100% patients of severe hemophilics are on replacement, regular replacement therapy, and our mild and moderate are on demand. Our medical school is a first medical school in Kashmir, J&K. Is a mother medical school of every medical colleges whichever you have been grown up till date. So it was initiated in 1959. So we have all sort of super specialties with us. We have all sort of comprehensive facilities with us, starting from neurosurgery to pediatric surgery to orthopedics to every thing, hematologist and everything we have there. Even psychiatry, and we are giving all care, and it is only because the availability of the factors you can make change in the life. You can just imagine in last 1 year we had 3 IC bleeds. Life-threatening bleeds, nobody comes out of the life-threatening bleeds. It was only the availability of the factor. They all 3 are surviving, are there. Recently one has driven to the Leh, and it is a remarkable achievement, and many people have entered into the NEET. They have qualified NEET. They are postgraduate scholars. Some are pursuing MTech, and we have empowered really the people, and they are happy. It is only that you have availability of all facilities, you have availability of drugs, and the factors are there, and till date we are very much satisfied. Thank you.
Thank you, Doctor. So in the interest of time, since we are the only session between you and dinner, I would like to ask some very short questions to some of the panelists, so we can break early for dinner. My first question is, how do you tackle early diagnosis? I would like to ask this question to Dr. Sonia. Early diagnosis in your state. Sonia, ma'am. Yes.
Yeah. So our state, that is Andhra Pradesh, coordinates with teaching hospitals, and we have 5 ICHH centers, that is integrated centers for hemoglobinopathies and hemophilia. So these centers are mostly, these 5 centers in 5 different districts with the teaching hospital or the government general hospital are more equipped for diagnosis, especially when it is not a routine test and you need a advanced coagulation profile and you need a HPLC or anything. All that is set up in the ICHH center. And the diagnosis part is dealt like that, and we are looking forward to upgrade these centers to also have a daycare center along with it, so that it becomes a more privileged HTC for the patients to take daycare treatment for the hemophilia factors or whatever therapies available.
Thank you, ma'am. So we'll move on a little bit to an older age where multidisciplinary care is very important. So I would like to ask, how can multidisciplinary care help in betterment of the life of a hemophilic, to Dr. Nidhi?
Yes, multidisciplinary treatment part is very essential in this. First is diagnosis, another is treatment, and then prolonged treatment, and then the disease part, that the patient has to live with the disease. And then we have to treat the disease both physically, psychologically, and the patient has to be stable and lead a healthy life to rule out the brain crisis. And at the time of brain crisis, the emotional support is to be given to the patient. That is given first from the family members, then from the staff who in the daycare centers where the pain crisis is being managed, and then the outcome or multiple bleeding sessions which the patient is facing and the complication of that. And with that, if the patient is bleeding all the time and is resulting in with hepatic complications or renal complications and mental distress, the patient which he or she is facing, and then the joint arthrosis which the patient is having, all those things is to be ruled out by multidisciplinary action, which our previous speakers have mentioned very well. So coordination between all those things is to be maintained so that a healthy lifestyle can be given to a hemophilic patient, with which the patient has to survive and live a healthy life throughout as far as the survival is concerned, and to give a patient a life which is prolonged, happy and coordinated. For that, psychiatric counseling, physiotherapy and multidisciplinary action is very important. Thank you.
Thank you, doctor. Thank you very much. So next, in again hemophilia treatment chain, the most important aspect is to actually have access to treatment. So I would like to ask, can you elaborate on the importance of proper distribution of hemophilia treatment centers and medicines to Dr. Parul?
Actually, all the medical colleges should have well-equipped hemophilia daycare center, and the procurement and the supply of the drugs are equal for all the centers. But the important thing is there a dedicated team should be there, not only the doctor, but the doctor, nursing staff and physiotherapists and the multidisciplinary other doctors that as and when required, and the coordination of the patients also. Their cooperation, trust in the hemophilia daycare centers, policies, and of course the pharma companies' academic update to the doctors, recent updates or research related promotion or something like a support to the doctor, and of course HFI's support to guide us and to emphasize on the some policies as well, and of course authorities support. So these all should be implemented to all the district level places as well. Medical college is always emphasizing on, because lots of projects are going on in our institute or other medical colleges. So we are used to do the work like in a team. But sometimes at the district hospital, this may be lacking, only one doctor is looking after, and most of the time they have require some more knowledge or training as well as. So most in promoting aspect to update, or I can say the advancement of the treatment of hemophilia, I recommend regular CME or training of the CHC, PSC doctors as well as a resident doctor when there is a medical college. Because there are lots of, we are experiencing, there are lots of updates going on, lots of research are coming for the treatment improvement in the management of the hemophilia, and now the things are going as a comprehensive care of the hemophilia. So I suggest all those who are involved in this part of the hemophilia advanced treatment, this thing, improvement, they should also exchange their ideas, thoughts, and they can extend their policy, what they are facing or what they are doing well. So that can be the main prime for us to give the comprehensive care in form of improving the quality of life. Not just we are treating only hemophilia or just replacing the drug. We have to take care of all the aspects of to give the best quality of life. So at our state, we are regularly at the state level with the authorities, we are planning twice in a year for all the states, all the districts, stakeholders, those who are involved in this, is regular CME. So exchange of our ideas with them, and we are helping them to also make it sure that it can be done. Our experiences at medical college we share with them. They are been encouraged, and this has been required, and it is possible to do this.
Thank you, ma'am. So again, availability of factor is one thing, but what if it was available at your home? So I would like to ask Dr. Ritu to shed light on how important home therapy is.
As I mentioned earlier, home therapy, it was started in our state way back in 2012, and then the prophylaxis part was started in 2017. It is very important because in our state, we have very different demographic areas. So many people are coming from far-flung areas, rural areas, hilly areas. So they won't be able to come for the treatment always. So we have given them training to take the medicine by themselves. So it has helped them during their initial part of the bleeds also, in the prophylaxis also, and mainly during COVID also. So it really helps them as it reduces their hospital visits, their traveling time, and also it helps them psychologically and mentally, so that they don't have to visit the hospitals again and again. And that's it.
Okay. Thank you, ma'am. So final question of this session. As you're all aware, HFI has developed and is going to be releasing the national treatment guideline. So would you be willing to adopt such a guideline in your state, or would you suggest your state to adopt such a guideline? I would like to ask this question to Dr. Bilal.
Yes, surely. HFI is coming with a guidelines. So surely, because it's a one country, one treatment, so we'll surely adopt the guidelines, whatever is required, because the guidelines is not, it's not only one mind, it will be behind the guidelines. There will be many expertise minds behind the guidelines, so it will be very easier and I mean less challenging job for every center to have a good guideline from HFI, and surely we can use the guidelines. There is no issue.
Thank you, sir. Again, in the interest of time, I would like to end the session here. I would like to thank all our esteemed guests on the stage. Thank you so much for spending your time to be here, and thank you everyone for being here for the session.
Around 2 years back, we detected a case which is also a clotting disorder of blood called Glanzmann's thrombosthenia among small child. And we tried to, because mother was insisting that try and see if this Glanzmann's thrombosthenia is included in the disabilities. 21 disabilities are already there. We tried with central ministry, but that requires amendment at the Central Act and all that. So they said it's not possible. So through State Child Right Commission, we tried and we got that Glanzmann's thrombosthenia included in the rare diseases. It has been included so that that benefit of one time 25 lakhs earlier, which was available for any major treatment, now it is increased to 50 lakhs from the Central Health Ministry. But just wanted to share that it is now in the rare diseases. It has been included after our initiative in Goa. Thank you.
Hello. Thank you everybody for having stayed here, and I thank all the panelists. And now the next session is just a short session because it's very important for the reason that majority of the people are telling that we don't have factor in the various states, we don't have factor, we don't have factor. And the industry is saying that, you know, they're not using the tender. So we have the industry symposia now, and you can ask the questions and we will address why factor at various states are not available or why there is a supply problem. So,
I request the panelists to be here for the felicitation, please. I request Dhanmani Rajvanshi, Samar Singh ji, Dr. Maganti Prasad sir, Aryabhat sir, Dharam Singh, Dinesh ji, and Jagdish ji to please come over to felicitate our esteemed panelists. We are starting with the next session. The next is a panel discussion on treatment and supply, the industry perspective. The moderator is Dr. Vyankatesh Parlikar. Yeah, Dr. Ritu Sarkar. Yeah. Dr. Ritu Sarkar, KVS Prasad. Dr. Sonia Mohan, Dr. Bhaganti Prasad sir. Okay, okay. I will please Dhanmani I request Dhanmani to please felicitate Dr. Ritu Sarkar. I request Samar Singh EC member HFI to please felicitate Dr. Kavindra Lal. I request Dr. Maganti Prasad sir to please felicitate Dr. Sonia Mohan. I request Arya Bhatta sir to please felicitate Dr. Nidhi Gwalde. I request Dharam Singh to please felicitate Dr. Bobby Gulati. I request Dinesh Vadadia sir to please felicitate Dr. Parul Bhatt. I request Sri Jagdish Sharma to please felicitate Dr. Bilal Ahmad Sheikh. Dr. Parlikar, the next moderator, is a person with severe hemophilia A. He is a pediatrician and is the consultant pediatrician at ESIC Hospital, Kolhapur. He will introduce the next panelist.
Good evening all. Thank you so much HFI for having me here for this 8th program on hemophilia, initiative on hemophilia care. Thank you all for attending it and being kind and listening at the late hours. So without wasting the time, the panel discussion is on the topic of hemophilia care from the industry perspective. So we all know that how important it is in hemophilia to have medicines, the drugs, and we all know that the treatment paradigm has shifted in last few years a lot. From taking cryoprecipitate and plasma, we have got a new products. For that regard, we are thankful for the pharma industry to improve the hemophilia care. I would like to welcome Dr. Monica Puri. She is a representative from Roche. I would like to welcome Mr. Ankit Panthri, who is a rare disease head from Takeda. Welcome, ma'am. I would like to welcome Mr. Suneet Sharma, who is a representative from Novo Nordisk, our knowledge partner. I would like to welcome Mr. Kishore Gupta, who is a representative from Pfizer. and one of our blood brother, Mr. Chittaranjan Das, as a patient representative, who is RCC for East HFI. So without wasting much time, I would like to ask the first question, is that like, I would like to ask all the panelists basically, what are the products available from your companies and your industry for hemophilia care? And what is the vision or principles your company holds for hemophilia care in India? I'll start with Ankit sir.
Thank you. Yeah, thank you so much for HFI, for having us here. Answering this question, I think we are in a very interesting phase in hemophilia care, where we see lots of new products coming in. India is a country where the unmet needs are many. We still have many patients who are undiagnosed. We have many patients who are still waiting to get higher standards of care. And we are looking at uplifting the ecosystem comprehensively. Now, from a product pipeline point of view, any company at any point in time is always evaluating options. We do understand that advancement is the name of the game. And for the future therapies, we are all getting ready. In terms of the specifics, I won't comment on that because it's, it's a privileged information. But I can only say that we believe, Takeda believes that in the country today, with whatever products we have today, there's enough scope for us to work towards patient upliftment and improving the standards of care.
Thank you, sir. I would like Dr. Monica ma'am to answer from Roche point of view, what products do you have and what's your vision for hemophilia?
First of all, let me apologize because I think we are keeping you away from dinner. So I hope we will make most important remarks that you may find helpful for the time that you're waiting for your dinner. So as the question is on our products, most of you have heard about emicizumab today. So definitely it has been a groundbreaking therapy, especially when hemophilia, where a patient would just bleed and bleed to death. You have a product now which will not only prevent bleeding, but you could actually stop thinking that you are a hemophilic if you start emicizumab in your life very early as a patient of hemophilia A. So I think as a company which is 128 years old, Roche has always believed in doing now what patients need next, which means years ago, decades ago, when we thought that hemophilia is a death sentence and hemophilic will die of bleeding, we are talking about a time where we have to now convince hemophilics on emicizumab, please don't forget taking your medicine because you just feel you're so healthy.
Yes.
So I think innovation is in our blood, innovation is in our DNA, and all I can promise you today, the magic, the wonder that you're seeing with emicizumab, Roche is already thinking of how better we can do with our next generation of drugs. So of course, it's a privileged information, but I can only tell you that you dream of it and we will bring it for you. Thank you.
Thanks a lot, ma'am. Now we will ask Mr. Suneet Sharma, sir, who is from Novo, to give their product availability and about the vision of Novo towards hemophilia care.
Yeah, first of all, thank you very much, Dr. Venkatesh, for this question. And first of all, I would like to thank HFI for giving us this opportunity to showcase our presence in Indian market. So I think Novo Nordisk has started his journey with Novo 7, I think in 1995. So that is the first thing which we launched globally, and then in 2005 we came up in India. And then I think we came to recombinant factor 8. Then we came to extended half-life factor 8 and factor 9, which is called as Exparoct and Refixia. And we are not stopping our journey here, as we are committed towards this cause and driving change in hemophilia for decades. And then we are going to continue for the further decades also, with bringing our anti-TFPIs and even mimetic of factor 8. And also, we are also not only stopping us in hemophilia, we are also going to enter with hemoglobinopathies. So I think we are very much committed towards rare blood disorder, and we will continue to drive this change in future.
Thanks a lot for having brief idea and vision about hemophilia and hemoglobinopathies. I would ask the same question to Mr. Kishore Gupta from Pfizer.
Yeah, possibly we are the late entrant in this entire hemophilia business. We already had colleagues.
Close.
Okay, all right. I'm so sorry. So we are late entrant in this hemophilia entire scenario, but we understand the sensitivity involved around this entire disease. We came in India in 2019. Though we were there in the global market for a very, very long time. But I think when we came, we thought it's another disease, it's another therapy, but maybe after a couple of years we realized rather that, no, it's very sensitive basically. Currently we are having two factors here in India. One is the factor 9 and factor 8. But I think the way forward, maybe a couple of years, you will find that we are dealing with gene therapies, we are coming with Mastricimab, and then so many products. We are very happy that we will be able to contribute to this entire pool of population in India, those who are having real tough time actually, as far as the access to medicine is concerned.
Thanks a lot, sir. I'll move to Mr. Chittaranjan Das to ask the question about the patient perspective, considering the Indian market and the availability of the newer therapies with the participation of the pharma industry. How does it help in a from patient point of view in hemophilia care?
So, thank you Venkatesh for your question. तो यहाँ पे जो अभी हमारा जो ये IHC प्रोग्राम हो रहा है, तो ये एक छत के नीचे, एक पैनल के नीचे सारे ब्यूरोक्रेट से लेके ट्रीटिंग फिजिशियन से लेके पेशेंट प्रोग्राम्स जो रन करते हैं, जो ऑल ओवर पैन इंडिया हमारा HFI के चैप्टर से सारे लोग एक छत के नीचे एक कॉम्प्रिहेंसिव टाइप का हेमोफिलिया केयर को कैसे आगे बढ़ाना है, सब लोग मिलके आगे इसको, जो कहते हैं कि एक साल के लिए एक साल में एक बार होता है, तो हम उसको एनर्जेटिक वे में करते हैं, और ताकि आगे चल के ग्राउंड में वो साल के लिए जो डेवलपमेंट्स होना है, एक हम कहते हैं कि इसमें प्लानिंग होता है कि इस नेक्स्ट एक साल में हमको क्या करना है एक्चुअली। तो ये बहुत ही अच्छा प्लेटफॉर्म है, लेकिन हमको अभी जो रिसेंटली जो हमको लग रहा है कि बहुत सारा दिक्कत हो रहा है, तो उसमें से मैं चाहूँगा कि खास करके इंडस्ट्री से जो सपोर्ट चाहिए हमको, वो तो मिल ही रहा है पहले से, लेकिन उसमें थोड़ा अभी जो लूजनेस आया है कुछ चीज़ों में, तो मैं चाहूँगा कि वो सारा पॉइंट आउट करने के लिए पहले तो मैं रिक्वेस्ट करूँगा कि जैसे ही पेशेंट सपोर्टिव प्रोग्राम्स हमारे जो फार्मा इंडस्ट्री चला रहे हैं, जो हमारे ब्लीडिंग डिसऑर्डर पेशेंट के लिए बहुत हेल्पफुल हो रहा है हेमोफिलिया केयर को डेवलप करने के लिए, उसको और थोड़ा बढ़ाएं, सो दैट चाहे वो इनहिबिटर पेशेंट के लिए हो, या हेमोफिलिया ए के लिए हो, बी के लिए हो, वॉन विल्सन डिजीज के लिए हो, या फिर अदर ब्लीडिंग डिसऑर्डर के लिए हो, तो उसमें जो पेशेंट सपोर्टिव प्रोग्राम है वो ज़्यादा लॉन्च करें। सेकेंड चीज़ ये है कि अभी जो रियल वर्ल्ड चैलेंज है अभी नेक्स्ट लास्ट ईयर से हो रहा है कि टेंडर में पार्टिसिपेट होना कुछ स्टेट में बंद हो गया है, तो वो हमको बहुत दिक्कत होता है, क्योंकि मैं एक फ्रेश एग्जांपल दूंगा तो सबको समझ में आएगा। जैसे कि पहले जब हमारा सिर्फ प्लाज्मा ड्राइव फैक्टर मिलता था, उसके बाद में हमने रिकॉम्बिनेंट भी हर स्टेट ने अपने टेंडर में डाला, तो क्या हुआ कि जो मान लीजिए हमको 100% खरीदना है फैक्टर 8, तो वो डिवाइड हो गया, 50% किसी स्टेट में प्लाज्मा को चला गया, 50% रिक्वायरमेंट रिकॉम्बिनेंट को चला गया। अभी क्या हो रहा है कि प्रोक्योरमेंट में अगर रिकॉम्बिनेंट का टेंडर नहीं हो पा रहे, या फिर फार्मा के लोग उसमें टेंडर में पार्टिसिपेट नहीं हो रही, तो उसका टेंडर कुछ स्टेट में हमारा रुक गया है, सो दैट प्लाज्मा के जो 50% क्वांटिटी में आप 100% का कवरेज, ये बहुत पेनफुल सिचुएशन है। तो मैं रिक्वेस्ट करूँगा कि इसको जितना जल्दी आप लोग सॉल्व कर लेंगे, चाहे इंटरनली कुछ भी प्रोग्राम हो, तो टेंडर में पार्टिसिपेशन हमको चाहिए हर स्टेट में फार्मा से, ये हमारा एक चीज़ है। तीसरा चीज़ ये है कि हम लोग चाहते हैं कि जैसे अभी हमारा नेशनल हेमोफिलिया रजिस्ट्री है, तो उसके हिसाब से अभी वर्ल्ड में हम जो डायग्नोस्ड हेमोफिलिया पेशेंट के हिसाब से हम नंबर 1 हो गए हैं। तो हम चाहते हैं कि जैसे कि मतलब दूसरे ग्लोबली जो भी प्रोडक्ट लॉन्च होता है, तो कितना तुरंत जैसे कि इंडिया में भी वो प्रोडक्ट आ जाए, तो ये एक हमारा प्रोस्पेक्टिव है। और हमारा स्ट्रीमलाइन होना चाहिए, जब भी कोई टेंडर निकलता है तो सप्लाई चेन मेंटेन में थोड़ा टाइम हो जाता है, टेंडर मिलने के बाद भी कोई 2 महीना 3 महीना लगा देते हैं सप्लाई में, वो क्विक हो सके, बस उतना ही हो जाए तो अभी के लिए मतलब हम सस्टेनेबल मॉडल में हो जाए।
Thank you so much for highlighting the issues from the patient perspective. But I would definitely thank all the industry people for coming with the innovative things, because being a pediatrician, being a patient, I can understand it is difficult to come up with a new drug. For one drug to come in the market, thousands of the drug go in the waste, and all the efforts put behind that go in vain. No one will understand that. It is really difficult to come up with a new product, and you people are doing your best to come up with the products, and considering the kind of a rare disorder. So I'll come with the next question. That is, I'll ask Mr. Ankit sir, is what are some challenges, regulatory challenges do you face considering the industry encounters while working with the government tendering and all the stuff, and how can patient organization, government, and we as patient organization, government can help to improve the situation?
So I will look at your question in 2 parts, break it down to 2 parts. One is the regulatory hurdles, regulatory challenges. Now, regulatory environment in the country is, as we all know, is dynamic, evolving, and it's complex. Right? There are so many regulations, rightfully so, but at times what really happens is that to appreciate those regulations and to adopt to them takes time. My recommendation here is that it should be very consultative in nature. There are very many stakeholders apart from regulators, the users, the companies, the consumers, the patients. I think all they need to contribute to the guidelines so that we remain pragmatic, we remain forward-looking, and make it an environment where innovation thrives. And good number of companies with good number of products, good brands can come in and can have expedited access to patients in the country, for all those unmet needs. That's from the regulator point of view. Another aspect you spoke about the tendering organization. Now I heard this point coming in that we need a nation policy on hemophilia. I think we also need a nation policy of procurement which is consistent across the states. There are so many states, as you all know, and all of them have different set of terms and conditions, procurement manual, procurement guidelines, which is good to have. But what is done in turn is that there's a lot of element of uncertainty, unpredictability, which also has got its own costs. So as long as we can standardize this, I think it's going to help entire community, all the companies, all the stakeholders. It will probably incite more visibility as to what kind of demands, as to what kind of consequences for what kind of participation, and all that will really going to help finally the patient.
Thank you so much for giving your knowledgeable answer with your experience to come up with the tendering and regulatory problems. I'll continue with Mr. Suneet sir for asking what are the factors which are limiting basically tender participation from the industry, and what government and what we as patient organization do to improve the same.
Dr. Venkatesh, I think it is a good question, and already I think it is a burning question which is raised by even Chitto also. That participation. I think we always feel that why company is not participating, but we don't see what are the limitations is faced by the companies, because I think most of the products are imported. The global scenario changes, as well as the tender terms and conditions, as Ankita highlighted, that every state has different tender terms and conditions. Some has 60 days supply, some has 90 days, some mention the mention the quantities, some doesn't mention the quantities. So in that current environment, to plan up any tender. So usually we as a MNC, I think all the MNCs focus on the advanced planning. So maybe 1 year, 2 year down the line. So planning in that scenario, I think it's become tough. So we always try to put up our best efforts, and whatever we can ask our global colleagues. So they try to fulfill it, but all the things plays global scenarios as well as the internal dynamics to part in that tender.
Thank you so much, sir, for sharing your experience. I would go to Dr. Monica, ma'am, to ask her about the what you think about we are giving it is important to know pharma perspective why they are not participating in tenders. Same way, we would like to know from you what are the areas should we focus more upon, like awareness, standard treatment guidelines, or screening from your perspective.
See, when you ask me from my perspective, I will speak from 3 perspectives. One, as a doctor myself. Second, as someone who's been a policy maker herself. And third, now from the corporate side of the world. Because when you say we, then we is all of us.
Yes.
We is also patient, we is also doctor, we is also society, and we is also government, right? So सबसे पहली मुद्दे की बात ये है कि पता कब चलता है कि किसी को हीमोफीलिया है? पता तब चलता है कि जब उसका डायग्नोसिस टाइम पे होता है. तो somebody had mentioned about diagnostics. I tell you, in India, the diagnostic rate for hemophilia is 14%, average to global. इसका मतलब कि अगर 25,000 मरीज आज आपको हीमोफीलिया के दिख रहे हैं, तो लगभग 1,40,000 तो कहाँ है पता ही नहीं है. And most of them lose their life because they are not even able to reach the hospital. If for God's sake they reach the hospital, then do we have the right test primary level pe, district level pe, tertiary level pe, and then hemophilia treatment centers. And if he is lucky enough to get tested in time, then the question comes whether the treatment is available. And what is the right treatment? Right treatment could be anything. But क्या पेशेंट को कभी ये बताया जाता है कि तुम्हारे लिए राइट ट्रीटमेंट क्या है? अगर आज एक पेशेंट से ये पूछा जाए कि तुम्हें ऐसी दवाई दे दें हम कि तुम्हारा खून रुक जाएगा वर्सेस तुम्हें हम ऐसी दवाई दे दें कि तुम्हें कभी ब्लीडिंग ही ना हो, तो फर्स्ट एंड मोस्ट इम्पॉर्टेंट थिंग इज कंसेंट. आर वी कंसल्टिंग द पेशेंट ऑल्सो दैट व्हाट डज ही रियली वांट? एंड देन कम्स अ क्वेश्चन, ही वांट्स अ गुड लाइफ. As a government, are we doing everything to provide him the good life then? Which means he deserves to go to the school, he deserves to play, he deserves to get employment, and he deserves to lead a near normal life. And if that choice is available, why should we not give that choice to that patient? And then comes the point, if we give that choice also, how do we make it sustainable? कि निरंतर एक रेगुलर तरीके से वो दवाई उसे हमेशा मिलती रहे, जिसका मतलब उसके लिए जो भी संसाधन चाहिए, वट एवर फाइनेंसेस आर रिक्वायर्ड, वट एवर पॉलिसीज आर रिक्वायर्ड, वट एवर ट्रीटमेंट गाइडलाइंस आर रिक्वायर्ड, वी विल मेक इट हैपन. एंड व्हेन आई से वी, government should come in, tell the industry, I want this on a sustainable basis for all hemophilia A patients. Can you provide that? And that will solve for the tender issue also, because you can forecast better and say कि for these many patients, this is what is required. So my point of consideration here is we need to solve it for all. Yes. If you solve it in patchwork, you will only get a patchwork treatment, which means you may be able to prevent one bleed. एक बार बच्चा intracranial bleed हो गई, joint में bleed हो गई, एक बार को तो रोक दोगे, बचा भी लोगे, पर जो एक बार नुकसान हो गया, जो उसके अंदर weakness आ गई, आप उसके बाद जो मर्जी जोर लगा लीजिए, he will never be back to normal.
Yes.
So all we need to work towards, together need to work towards is make sure that we give him that normal life, which is possible. Yes. And where does industry come in here? And I will just say from my perspective, whatever we have committed, because many things I've also heard कि आज ये patient support program दे रहे हैं, कल को ये खींच लेंगे, ऐसा कुछ नहीं है. As Roche we can commit. If we have agreed that we will support a patient by giving free medicine or by giving other physiotherapy and all, we will continue to do that. Yes. But trust is two ways, and that is what we need to build.
Thank you. Thank you so much, ma'am, for highlighting your view about the issue. I would like to ask Kishore sir about what are the industry perspective about the availability and the distribution of the drugs.
Before I go to this, two more points adding to what Sunit said, that why don't we participate in tenders? I think possibly many of you may not be even aware about that. The tender authorities, they treat this also as any other general medicine. So they will put a condition that you have to supply a goods of having 80% shelf life or 75% shelf life. Please understand it's an imported product. We are planning it and we are not able to supply. Now what happens? We'll end up paying huge amount of penalties to them. Now, few tenders, they will float. We have already asked for the stock, they will scrap it. Few tenders, they have asked for 100, they will take 500 from us. Now just imagine where we are. And the last thing was basically, now see the pricing now basically. By end of the day, pricing is also important. And all these issues basically leads to maybe the inadequate distribution of the factors to many states. We are not, sometimes we do not participate, we are not in a condition to participate. That's what is impacting the distribution of the factors, whether it is 7 or 8 or 9, everywhere. Possibly what HFI, because you are a very, very powerful body. आप लोग यदि जाके मिनिस्ट्री ऑफ हेल्थ और फैमिली वेलफेयर को रिकमेंड करेंगे तो हो सकता है वो कुछ कंडीशंस चेंज करें अपनी. हम तो जाके उनको मिलते ही हैं, बार बार रिप्रेजेंट भी करते हैं कि आप इनके टेंडर को सेपरेट करिए, इनको स्पेशल कंडीशन में डालिए, आप इनको जनरल बना के मत करिए, बिकॉज दीज आर नॉट पैरासिटामोल, दीज आर नॉट नॉर्मल एंटीबायोटिक्स. They are listening to us also, but I think it's a long way to go.
Thank you. Thank you so much, sir. We will definitely take your inputs and we will try to convey. I'll go for the last question, which will be, I'll ask Mr. Suneet sir and Dr. Monica ma'am, please in brief. Like we know that we are coming with the new products and there are adverse drug reactions to every product, not I'm saying only medical for pharma. Hemophilia care, but whatever medicines comes, they have some adverse drug reactions. So what are the tools you have to of reporting of adverse drug reactions, and what are the steps taken for the mitigation to prevent the reoccurrence of it from your industry? You and Mr. Samit.
Okay, I can start. First of all, I will speak on Roche behalf because we are importing the drug to India. तो बहुत इम्पॉर्टेंट है पेशेंट से ज़्यादा ऑर्गेनाइजेशन के लिए, क्योंकि पेशेंट एक होता है, ऑर्गेनाइजेशन के लिए अनेक होते हैं. तो एक भी गलत रिस्पॉन्स, एक भी ADR, एक भी सीवियर रिएक्शन एक्चुअली में रिएक्शन है कि नहीं है, पहले वो जानना बहुत ज़रूरी है. तो अगर आप देखेंगे तो हर प्रोडक्ट के साथ देयर इज़ अ पेशेंट फॉर्म, देयर इज़ अ डॉक्टर फॉर्म, देयर इज़ PI, प्रोडक्ट इंसर्ट ऑल्सो. एवरीथिंग हैज़ अ डिटेल. If you have any reaction, kindly immediately report, and you will have the number of the patient safety helpline also. And the moment we get a signal like this, then first thing that we do is we have a global hub. That signal is reported at a global hub to check whether it is actually an adverse event or it is drug related also or not, or is it just a causal association. It is thoroughly evaluated. Once it is evaluated, the report is sent back to the country, and then it is even informed to the CDSCO, जो हमारी drug regulatory organization है, to basically give them details whether this was a severe reaction, adverse category or not. And based on that, the report is also being discussed at the discretion of DCGI as a condition compliance. कि क्या इसके चलते हुए ये फर्दर कोई चेंजेस करने हैं आपके इंसर्ट में टू द नॉट. फॉर्चुनेटली आई कैन टेल यू टुडे, एटलीस्ट विद एमिसिजुमाब वी हैव नॉट सीन adverse reactions, which gives us confidence that there is lot that has already, the company has invested in clinical trials to understand what could be the potential side effects or adverse effects and how do we mitigate. So that's like a process, and I think for everyone.
Yes, just from the patient point of view, like people are not aware what is done, what to be done after facing an adverse drug reaction. That is what we wanted to know.
Yeah,
so
as highlighted by Dr. Monica, so I think same way we also have pharmacovigilance reporting system where where patient can report even through social media also. So they can use Twitter, Facebook or any medium, and even they can report through their SCP or even our company representative or even our channel partner. So request will come to our system, then it will be properly investigated. Then as Dr. Monica highlighted that we are a global company, so we'll send that sample to global, and then the report usually comes in 1 to 2 to 3 months, and then we will again reiterate it whether it is really adverse reaction or it is a side effect or whatever. So we will communicate to the respective person.
Thank you so much for all of you for sharing your precious time and giving the pharma perspective. Dr. Cecil sir has a question. We will take it. Mic.
Say for example you got a problem that you import, you have to plan, and therefore so give us a good tendering policy, ideal, okay, and we will work towards it, because it can't be that you are getting a tender and you're not able to supply in time, or you don't participate in tender at all because of various issues. So we actually want people to apply. So a common people together, all of you can sit down because your products are different.
Yes.
So, and a common tendering ideal policy which might enable you to help, and we can facilitate that. So I thought that, because we also don't know what the problems are. So when we sit down in technical committees, we can tell them that you can't do this, you can't do that, because I don't know. When I sit in the technical committee, I look at itna factor 8 hai, itna factor 9 hai, itna ye hai, bas khatam. But I do not know so if I'm sitting in the technical committee, we can tell them that itna life nahi chahiye, itna we can tell. So if you have a common document which you can probably talk to each other and give us the thing, and we will take it from the HFI and try to influence the policy makers to streamline the process, because you said you wanted a good tendering policy.
Yes.
So give us a document, we will follow it.
Thank you so much, sir. This is a very good point of view. Like, we are coming with the hemophilia guidelines, and Mr. Ankit sir said that we should have a national policy for tendering. You guys, please give us the things so we can follow up with the government. Thank you all for listening us. Once. Yes.
ये सब फार्मा कंपनी का हमारा एक HFI की तरफ से एक रिक्वेस्ट है, हमारा कुछ ऐसा कुछ एक्सपीरियंस है कि टेंडरिंग में अपनी तरफ से कुछ पार्टिसिपेंट नहीं होने की वजह से हमारा हीमोफिलिया परिवार को बहुत नुकसान होता है और बहुत परेशानी को सामना करना पड़ता है। तो हमारा फेडरेशन की तरफ से आपको रिक्वेस्ट है कि आप सब टेंडरिंग में पार्टिसिपेट करें। उसमें कुछ आपको टेक्निकली कुछ न कुछ दिक्कत आती होगी, लेकिन वो भी आप अपनी तरफ से सोल्व करते हुए आगे बढ़े, और थोड़ा आपका मुनाफा देखने की वजह से हमारा हीमोफिलिया परिवार का परेशानी को थोड़ा आप नज़र सामने रखिए। थैंक यू।
Thank you. और हमें पता है कि
as a follow up to his ask, very fine ask. See, my request is for you to realize why our company is here. What is our fundamental purpose? There is no drug if there is no patient. So all of us appreciate that, recognize that our ultimate purpose is to serve the patient. For us to be not able to participate, I can tell you on behalf of everyone over here, nobody likes it, because that's contrary to what we are here for, right? So if we are not in the position to do that, you can assume that there's something really critical which is prohibiting us. And answer to that is what Dr. Cecil just spoke about. Can we together provide our inputs, make recommendation, and government can review it and make it healthy and good for everyone else?
Yes,
right?
yes, we can do that after EC. We will discuss and we will do it. Yes, definitely. Thanks a lot, because pharma plays a drug. Like you said, if there are no patients, there is no drug. But we also need the drug. The need for each other is definitely same. So thank you so much for continuing your dedication towards hemophilia care, coming with the newer products, and sharing your issues about the tendering and unavailability of some things.
Can you tell us in the next few days a document that will, or at least guidelines, to be able for us to follow it?
Yes.
Sure.
Yeah? Thank you.
Thanks a lot for giving your precious time. Yeah, let them ask. I'm just thanking and yeah.
सभी को नमस्कार।
नमस्कार सर।
सभी सारे आप हमारे मित्र हैं। मैं आप लोगों से एक बात कहना चाहता हूं कि भारत में अभी फैक्टर्स की बहुत समस्या है, और इसके दो कारण हैं। एक कारण तो समय पे निविदा में प्रतिभागी नहीं होना या नहीं करना, एक तो समस्या बहुत बड़ी समस्या है। दूसरी समस्या हम लोगों के सामने आ रही है जितने भी चैप्टर के की पर्सन्स हैं कि फैक्टर की आपूर्ति नहीं करना, सप्लाई नहीं करना, लंबे अंतराल के बाद सप्लाई करना। आप सोचिए, जिस मेडिसिन के लिए हम लोग अभी हम यहाँ पर बैठे हैं, हमें यह पता नहीं होता है कि 1 घंटे के बाद हमें ब्लीडिंग होता है, होगा कि नहीं होगा। हो सकता है, होता भी है, कितने लोगों को इस कॉन्फ्रेंस में भी हुआ है। ऐसी परिस्थिति में अगर दवाएं हमारे पास नहीं हो, सरकार का सारा नीति हो, पैसा हो, डॉक्टर हो, चिकित्सा हो, सब कुछ उपलब्ध है, लेकिन अगर दवा नहीं मेरे पास हो और दवा खरीदने की क्षमता हमारे पास है, सबसे बड़ी बात है कि हमारे पास क्षमता भी है कि हम दवा खरीद सकते हैं, और दवा निर्माता कंपनी अगर दवा नहीं देती है तो हमारी क्या स्थिति होगी, आप लोग कल्पना कीजिए। प्राइस, रेट, क्वालिटी अलग बात है, लेकिन हमें दवा मैक्सिमम हम बात करते हैं कि हम पीएचसी तक ले जाएंगे। कैसे लेके जाएंगे जब हमारे पास मेडिसिन नहीं है, हमारे पास डिस्ट्रिक्ट में मेडिसिन नहीं है।
थैंक यू सर फॉर आपने जो अपना जो समस्या बताया, हमने वही अभी डिस्कशन किया है, और उनकी कुछ लिमिटेशंस है, लेकिन उन्होंने वही हमें बताया है कि वो भी अगर उनको किसी टेंडर में पार्टिसिपेट करने नहीं मिलता है तो उन्हें भी बहुत दुख होता है। तो अभी इसी बात पे हम हमारा भी ये पैनल डिस्कशन क्लोज करना चाहते हैं विथ प्रेम्स वोट।
Thank you all. On behalf of Hemophilia Federation, let's seriously work on this tender document. It's very well put. We understand, but there is a like what the emotions which we saw of Santosh is the reality. Yes. That is the ground reality. So we'll work on together. Okay. Yes. So it is. Thank you all for being here.
Thank you.
Thanks a lot for listening us.
Thank you all. I request our president to please felicitate our moderator, Dr. Venkatesh Parlikar. I request our VP Medical, Dr. Cecil Ross, to please felicitate Dr. Monica Puri.
Thank you so much, sir. It was nice.
Thank you, Sam. Well done.
I request our Vice President Finance, Jagdish Sharma, to please felicitate Mr. Ankit Pantri. I request our Vice President Development, Ramu Gadkar, to please felicitate Mr. Sunit Sharma. I request our President to please felicitate Mr. Kishore Gupta. I also welcome Mr. Vaibhav Nehra, Executive Committee Member, HFI, who is also going to be a host for the second day of IHC 8 for the closing remarks.
करते हैं। Ladies and gentlemen, esteemed guests, and dear participants, as we come to the end of day 1 of Initiative of Hemophilia Care, I want to express my heartfelt gratitude to each of you for your active participation and engagement. Today's sessions have been informative, and thought-provoking. And we were grateful for the expertise and experiences shared by our speakers and panelists. As we conclude this first day, I'd like to thank our organizers, the Hemophilia Federation India and the National Health Mission, for their tireless efforts in making this program a success. Now it's time to unwind and connect with each other in a more relaxed setting. We invite you to have dinner with us. And tomorrow, we look forward to another packed day of learning and sharing, starting at 9 a.m. We have an exciting lineup of sessions and speakers, so don't miss out. Before we close, I'd like to thank our speakers, panelists, and participants for making day one a success. Your contributions have been invaluable, and we're grateful for your commitment for improving hemophilia care. Thank you. Okay. हाँ? नहीं. I would like to specially thank our event managers and our host for the day, Dr. Anupama. Thank you all, and let's all move forward together.